ahead. So, continuing with the topic about dyselectrolytemia, we'll go to the next major topic, that is hyponatremia. So, we all know that this is one of the common electrolyte imbalances that we see in the ICU day in and day out. And probably this is one of the defining electrolytes for maintenance or sustenance of life, if we have to be more specific about things. So, in the this question can come in, be it theory or practicals. Theory, they might ask you just to, speak about the pathophysiology about a particular type of hyponatremia, or else ask you how to evaluate hyponatremia and to treat hyponatremia in particular. Sometimes this can be asked as a 10-mark question itself. Okay. In practical, it depends. They can go ask about hyponatremia in any of the places, be it your long cases or in the table viva sessions. So to start with, let us take an example of a case. So one of a 48-year-old male smoker, hypertensive, presented to the ER with malaise, poor appetite, and he also had seizures, that is GTCS, with low GCS score. His score was roughly around 10 to 11. On examination, he was found to have a BP of around 130 over 70 millimeters of mercury. His heart rate or the pulse rate was around 88 beats per minute. I already mentioned the GCS score. On laboratory evaluation, because of all of this issue, they found that the patient had a sodium value of 104, potassium 4.2, chloride of 94, bicarb was slightly higher with 26, with a Bunn of 16 and creat of 0.6 milligrams per deciliter. The osmolarity was found to be around 249, that is the plasma osmolarity, and the urine osmolarity was 415, with urinary sodium being 48 and uric acid 1.8. Patient had a normal thyroid function test and a cortisol level. CT showed a right lung nodule. So what is the probable diagnosis? Anyone? So it probably the case, right lung nodule, so probably a malignancy is what we are thinking. And so probably a malignancy induced SIDH is the appropriate diagnosis that I could come across in this given scenario. So this is what we usually need to understand whenever we come and see this patient, right? Patient has seizures. The seizure can be even metastatic induced seizure, or it can be a dyselectrolytemia induced seizure. So we should always give DDs. Okay, and along with that, we need to know the case in whole. So this kind of case presentation or a case vignette can be kept to you on the table viva. So read the whole thing. Don't jump and give an answer telling that it is hyponatremia induced seizures. If anyone asks you anything about a diagnosis, always tell the probable diagnosis with differentials. So that will help you understand the concept in total. Okay. So coming to hyponatremia per se, hyponatremia is defined as a drop in serum sodium concentration of less than 135 milliequivalents per liter. This is the most frequent electrolyte abnormality in a hospitalized patient. It is very common in critical care units, and it has also been shown to be an independent predictor of death, especially in patients who have cirrhosis and heart failure. So coming to the understanding of hyponatremia, we all know that the total body water comprises of both the intracellular fluid and the extracellular fluid. So if we have the intracellular fluid, it roughly weighs about 40% of the body weight, and the extracellular fluid roughly around 20% of the body weight. In the extracellular fluid, it is again divided into two compartments, that is the interstitial fluid and the plasma volume. And we all know very well that sodium is predominantly an extracellular ion. So the balance of sodium is very necessary to maintain day-to-day activities at the cellular levels. Any changes in the serum sodium value will have a very morbid effect on the patient. So coming to the significance of serum sodium, it is the principal cation in the extracellular fluid, the main functions being maintenance of blood volume, water balance and cell membrane potential, acid-base balance, nerve conduction. So in the normal human body, the sodium is actually very closely guarded. Okay, the centers which maintain the serum sodium is usually present in the brain, and this is tightly guarded by the osmotic mechanisms in the brain, which I'll be speaking to you about in the next slides. So at this particular time, I would like to say there are a few points that we need to know as from practical perspective. So hyponatremia can be divided at this particular time into a mild, moderate, and a severe hyponatremia. Mild hyponatremia being between 125 and 134. Moderate being 120 to 124, and anything less than 120 is classified as severe hyponatremia. Having said that, there is no single best number which can tell the severity of hyponatremia. If at all the patient is symptomatic, be it the patient has seizures, a drop in sensorium, or the patient is having some sort of hemodynamic instability or an arrhythmia, that has to be considered as a severe hyponatremia. So this is something that we need to understand. This is the reason why sodium is so closely guarded, because any change slightly on to the right or left causes major shifts of fluid and electrolyte balance in the body. Okay, so this is actually a closely knit balancing act. Okay, so whenever there is a drop in serum sodium in the body, or there is effective plasma volume reduction, there seems to be an activation of the baroreceptor input, usually present in the arch of the aorta or in and around the cardiovascular system. So this sends in active inputs to the CNS. Majorly, there are a few osmotic receptors like the subfornical organ or the posterior pituitary, which actually trigger the activation and release of antidiuretic hormone, which acts on the kidneys, especially in the collecting tubule, to retain sodium and water. So this is usually the mechanism by which the thirst and excessive fluid is regulated in the body. So for example, we started with the low volume, intravascular volume. So as soon as there is a low intravascular volume which is present, the baroreceptor senses that. And that low intravascular volume is actually taken over. And because of the low volume, the centers in the CNS, that is the osmoreceptors, can even sense what is the osmolarity. Probably it will also help us understand what is the amount of sodium present. And based on that, it prevents further loss of electrolytes as well as water by secreting the antidiuretic hormone from the neurohypophysis or the posterior pituitary, which the ADH goes and acts onto the vasopressin receptors in the collecting tubule. Okay, and thereby causing retention of sodium and water. So can anyone tell me, there is a close-knit circuit here present, right? So there is a blood-brain barrier. Despite that, how can this happen? Okay, so what I mean to ask you here is, if there is a blood-brain barrier, how is the osmoreceptor getting, getting the inputs? There should be a blockage, right? There should be a barrier. How is it bathed? So we need to know there are certain organs in the body which are called as the circumventricular organs. Okay, these parts of the brain, that is the circumventricular organs, do not have a blood-brain barrier. And that is the reason why whenever there is an alteration in the osmolarity, they can pick it up earlier, and any gross shift of fluid balance or electrolyte imbalance can be easily tided over. Okay, so these are called the areas where there is no blood-brain barrier. Usually there are six. The most common ones you need to remember is area prostrema, which usually has the vomiting center, the subfornical organ or the osmoreceptor area, which is usually present in the periventricular space. And then also we need to know one more thing, that is the neurohypophysis or the posterior pituitary is another place where there is lack of blood-brain barrier. Okay, this is one of the things that is physiologically important to understand what happens. Okay, so coming to dysnatremias, it is broadly classified as hypo and hyponatremia. The serum sodium can be easily understood by total body sodium divided by total body water. That is as simple as that. So any change in serum sodium is usually due to decrease in total body sodium, or it is increase in the total body water. It's as simple as that. Okay, so that will be accounting to the true hyponatremia. So if at all there is hyponatremia, it is usually due to water intake which exceeds the renal diluting capacity. Whereas if there is hyponatremia present, it is usually due to the inadequate water intake which is coupled with renal concentrating defects. Okay. So coming to the interpretation of serum sodium. So we all know this part that whenever there is hyponatremia, it is usually attributed to hypoosmolarity, correct? Which is because of this equation, which says 2 times this value of serum sodium with blood glucose divided by 18 and 1 by 2.8 gives us the value of the osmolarity, which is usually between 280 to 294 milliosmoles per kg, correct? So this is what we usually understand. So by and large, what we understand, if there is a drop in sodium, there should be a drop in osmolarity. And that's why any hyponatremia should be hypoosmolar, isn't it? But is that the scenario always? Unlikely. So let us see. Whenever we have a patient who comes to us, we usually see for dysnatremias, and whenever we have a dysnatremia, the first step anyone would order is to get a plasma osmolarity, correct? So whenever we order plasma osmolarity, why do we do so? If we have understood the concept of osmolarity clearly, we need to differentiate these patients between isoosmolar, hyperosmolar, or hypoosmolar. Whenever I say isoosmolar, it is, as I mentioned earlier, it is between 280 to 294 milliosmoles per liter. Hyperosmolar refers to conditions where the osmolarity is more than 295 milliosmoles per liter. Or else hypoosmolarity refers to the osmolarity being less than 280 milliosmoles per liter. So is this similar always? Then if it is so, what is isotonic hyponatremia? So at this particular junction, I want you guys to understand what is the difference between tonicity and osmolarity. I know this has been a confusing talk most of the times. To understand it in a very simple term, whenever we talk about osmolarity, we talk about osmotically active agents. Only they can attribute or contribute to the calculation of osmolarity. In the previous things, we took into consideration sodium. We can also take into consideration potassium. Along with that, we take in glucose and urea, correct? So in that case, osmolarity usually refers to the osmotic pressure, which is because of the osmotically active agents. I'm sorry, there is some noise. Please mute yourself, please. Whoever it is, Bhagishri. Suchitra, I think so. Sorry for the.
इसका जीपीएफ कितना 6 और 5 ही होगा
Bhagishri, are you around? Guys, please mute yourself.
गायत्री
Dr. Suchasmita, I don't know who that is. Okay, so let's go again. I'm sorry for the interruption. So let's start with osmolarity and tonicity to begin with. Okay, so osmolarity, as I was telling you, it refers to the osmotically active molecules which attribute to the calculation of osmolarity. And based on these osmotically active molecules, we grade them as iso, hyper, or hypoosmolar solutions. So if that case is there, what is tonicity? Tonicity usually refers to all the molecules which are present in a solution. Okay, they may be osmotically active or they may be osmotically inactive, but usually they attribute to the uh, transfer of movement of water from one compartment to the other compartment through a semi-permeable membrane. Okay, so tonicity takes into picture all the osmoles. So that is why whenever we talk about tonicity, the SI unit is moles per liter. But when we talk about osmolarity, it will be milliosmoles per liter. So that itself should help us understand the concept between tonicity versus osmolarity. Okay, so tonicity refers to all the solutions, that there may be anything which is present in the solution, but osmolarity refers to only osmotically active molecules. So coming to the concept of pseudo-hyponatremia and translocational hyponatremia. So whenever there is isoosmolarity, it can also be causing isotonic hyponatremia. As I've mentioned earlier, by and large, we always think that by the definition, if there is hypo osmolarity, there'll be decreased sodium. That need not be true. There can be pseudo or false hyponatremias. Where are the conditions which are seen? That is isotonic hyponatremia. That can be because of plasma proteins or triglycerides. Okay. Similarly, when there is hypertonicity, that is seen usually because of translocational hyponatremia. The translocation here refers to the movement of solutes and further on the water. This is usually seen in hyperglycemia and hypertonic saline. We all know the correction factors for hyperglycemia as well as the hypertonic saline causing hyponatremia. Okay, this is usually due to shifts of fluid. Okay. Coming to the true hyponatremia, it is usually hypoosmolar hyponatremia, that is usually less than 280 milliosmoles per liter. So in total, understanding what is true hyponatremia, it usually refers to hypotonic patients, which may be either euvolemic, hypervolemic, or hypovolemic. Okay, so these are the patients who contribute to the true hyponatremia. So coming to the assessment of volume status. So in the absence of either translocational hyponatremia that is seen in increased hyperglycemia, or pseudo hyponatremia as seen with increased paraproteinemias or increased triglyceridemia, the most important step, that is the next step after osmolarity calculation, is the assessment of the extracellular fluid volume status. It is closely monitored by the feedback mechanism, which I've already mentioned earlier. The feedback is usually to keep the osmolarity within normal range. But if it is unable to do so, the patient usually would end up in these three volume status. That is, either they might be hypovolemic, either they might be euvolemic, or hypervolemic. Okay, whenever we have these things, we need to assess this volume status usually by clinical methods only. It can be used also by adjunctive methods like ultrasonography. So always look for signs of dehydration like collapsed JVP, do an USG, check for the IVC status, look for signs of tachycardia, dry mucous membrane, depressed skin turgor. Okay, the presence of edema usually indicates a hypovolemic picture. Along with this, you can also run in some laboratory parameters, which are usually a complementary test that can be done. That is, both the serum and the urine specific gravity along with osmolarity. Okay. So whenever we see the hypoosmolar hyponatremia, that is hyponatremia with decreased serum osmolarity, based on the ECF volume as discussed earlier, we can divide them into three broad classifications. That is, when the ECF volume is decreased, that is the total body sodium is also decreased and total body water is also decreased. That is usually due to two reasons. That can be renal causes or extra-renal causes. In the renal causes, usually whenever it is present, the urinary sodium value will be more than 20. Okay, so whenever you have this, you should actually think of causes like diuretics, mineralocorticoid deficiency, salt-losing enteropathy, okay, or else sometimes even osmotic diuresis. Whenever it is extrarenal, it is usually seen that the urinary sodium value is less than 10, associated with symptoms like vomiting for any reason, diarrhea, or a third spacing of fluid that is usually seen in cases of burns, pancreatitis, or traumatized muscles, okay, like in case of rhabdomyolysis, etc. Coming to ECF volume, which the patient has a normal, that is euvolemic patients. So in such cases, you can see that the total body sodium can be a little reduced, okay? But the total body water may be normal or it can be increased. Such cases of euvolemic hyponatremia are usually seen in cases of syndrome of inappropriate ADH secretion. In these cases, usually the urinary sodium is more than 20. Okay, I'll tell you why this is in the subsequent slides. Okay, similarly, when we have an edematous patient, usually the total body sodium is decreased and the total body water is increased. There are two kinds of patients in which, firstly, if you have a patient who is edematous, you need to know the appropriate history. Along with that, if you're still unable to come to a conclusion, then we can use the urinary sodium as one of the markers to differentiate these group of patients. Okay, usually when the urinary sodium is less than 10, it is usually due to nephrotic syndrome, cirrhosis, or acute decompensated heart failure. Okay. Or else, if the serum sodium is more than 20, that usually attributes to the probable reasons being acute kidney injury or chronic kidney disease. Always remember one thing. Whenever we are talking about urinary sodium value, it goes up when there is problem with the renal system. The renal system is supposed to concentrate the sodium. So whenever the renal functions are suboptimal or it is impaired, the urinary sodium value goes up. So whenever you have a urinary sodium going up, based on the volume status, you can categorize them as whether they are hypovolemic, hypervolemic, or euvolemic. Okay. Hope this is clear. Going on to the specific scenarios, coming to hypervolemic patient, here we know hypervolemia means there is an edematous patient wherein both the sodium value and the total body water can be increased. Here, sodium usually would be normal, but because of increased total body water, it will be showing as low. Okay. So the causes here I have mentioned earlier as well. Based on the urinary sodium value, you usually categorize them into acute kidney injury or chronic kidney disease if the urinary sodium is more than 20, cirrhosis, cardiac failure, and nephrotic syndrome if the urinary sodium is less than 10. Coming to a condition that is a hypovolemic patient where both the total body water and sodium are low. So in these cases, again, we have to take into consideration both the urinary sodium and uh, the volume status. So if the urinary sodium is more than 20, as I've told you earlier, it is a renal cause. What are the renal causes that are usually associated with hypovolemic patients? Probably the patient is on a diuretic therapy, like in our case, which I've taken in earlier. The patient was on diuretics. Because of diuretics, probably the patient might have lost some volume, and that might have caused hypovolemia-induced hyponatremia. Patient might have salt-losing nephropathy. The patient can have a mineralocorticoid deficiency, or the patient in any case can be even on osmotic dialysis. If they are on these symptoms or medications, then these patients tend to have hypovolemia-induced hyponatremia. If the patient's urinary sodium value is less than 10, it is usually an extrarenal cause. That is because of vomiting, diarrhea, laxative use, or third spacing, as in cases of burns and pancreatitis. So in physiological state, because of maintenance of homeostasis, whenever there is hypovolemia or drop in intravascular volume, antidiuretic hormone is stimulated in the neurohypophysis. Neurohypophysis releases it, and that causes retention of both water and electrolytes. If the renal concentrating capacity is good, if the kidneys are functioning fine, that is usually if the urinary sodium is less than 10. If the kidney is not functioning normally, then the urinary sodium is more than 20. Then we need to think about renal causes. So what are they? I've already mentioned to you. These are the issues. So coming to diuretics. So diuretics, as I mentioned, it can be usually both thiazide or loop diuretics, which is the most common cause of hyponatremia. And the other type of diuretics is the potassium sparing diuretic. So what happens when there is diuretic induced hyponatremia? Uh, the urinary diluting capacity is usually altered. That is usually associated with hypokalemic metabolic acidosis. So whenever you have a patient who comes to you with hyponatremia, look whether the patient has metabolic acidosis or alkalosis. If the patient has one of these things, if he has a hypokalemia along with metabolic acidosis, most probably the drug might be a thiazide. Okay, this is what we need to understand. Sometimes we'll not be able to do a proper medical reconciliation when the patient presents to us, but an arterial blood gas analysis with a complete renal function test can help us narrow down the diagnosis. On the other hand, what happens if the patient is on a potassium sparing diuretic? There will be no hypokalemia or metabolic acidosis. So this is usually how we differentiate between the type of diuretics. So the treatment is usually cessation of the diuretic, and you have to choose an alternative agent. Restoration of volume, especially because if there is a vicious cycle which is going on because there is drop in intravascular volume, we will not be able to correct it. Always remember, sodium correction is always going hand in hand with volume correction. If we don't correct the volume, there will be a probability that ADH again gets stimulated and thereby again causes retention of water, causing hyponatremia. Okay, so always assess the volume status and also correct the volume status. Based on symptomatology and severity, sodium supplementation should be considered. If the patient is having a severe hyponatremia, probably we might have to start them on IV correction, or else sometimes oral correction should be sufficient enough. If the patient is on thiazide, also consider correcting potassium. Coming to salt-losing nephropathy. So who are the patients who can have salt-losing nephropathy? They're usually patients who have polycystic kidney disease, chronic interstitial nephritis, or patients because of medullary cystic kidney or analgesic abuse, or patients with partial urinary tract obstruction, be it BPH or any kind of pyelonephritis, or a patient with chronic glomerulonephritis. So what will these patients usually present with? These patients present with moderate to severe renal impairment, wherein the serum creatinine is between 3 and 4 milligrams per deciliter. So if at all a patient comes to you with this particular type of history, that is, the patient has deranged kidney functions, so attributing to a urinary sodium of more than 20 with probably polycystic kidney disease and hyponatremia, think about salt-losing nephropathy. So the diagnosis is usually based on these things. Patients usually need just sodium chloride supplementation. The usual normal 0.9% saline should be enough because they usually have to offset the ECF volume depletion, which is seen in salt-losing nephropathy. There is loss of salt along with water, causes dehydration, causes drop in intravascular volume, causes increased ADH, causes hyponatremia. This is what is supposed to be offset, okay? And that can be done by just giving sodium chloride supplementation. This can be started with IV correction later on, based on the symptomatology, based on the responses, titrated to an oral supplementation. Okay. So these patients sometimes, because of long-standing renal impairment, can have uremic dermatitis. And this can sometimes on presentation, when you're still evaluating, can mimic the patient of having that like a case of Addison's disease, that is primary adrenal insufficiency. Hope I'm clear about that. So coming to the topic of mineralocorticoid deficiency. So we all know that whenever a patient with hyponatremia comes to us, especially severe hyponatremia, we tend to send in cortisol, we send in TSH along with the osmolarity workup, right? So why do we do that? How does it affect? Okay. So the usual salient features which are usually seen in patients with mineralocorticoid deficiency is patients will have hyponatremia associated with hyperkalemia. Okay, they will have pre-renal azotemia, but their serum creatinine usually is less than 3 milligrams per deciliter. They can present with non-specific symptoms like weight loss, malaise, nausea, and vomiting. Okay, so in such cases, you need to test the cortisol level, as 8 a.m. is the ideal one. If you can do a random cortisol, that is also going to be sufficient. What helps us understand this or come to a diagnosis earlier here is whenever you send for urinary spot sodium, send urinary potassium as well. Okay. In such cases of mineralocorticoid deficiency causing hyponatremia, the urinary sodium will be more than 20, but the urinary potassium will be less than 20. Okay. So this helps us understand that there is an apparent mineralocorticoid deficiency. So if at all you have sent a random cortisol, that also comes down, and you have a urinary potassium less than 20, it's more or less understood that there is a probable mineralocorticoid deficiency. So this patient might need steroid supplementation. They say that the usual dose is dependent on the hemodynamic status of the patient. You can start with 25 mg TID doses of hydrocortisone. It depends on what the patient's status is. Along with this, you can also think of fludrocortisone. The dose of fludrocortisone is 0.05 mg per kg up to 0.1 milligrams per kg. Okay, this is the usual treatment dose that is suggested for mineralocorticoid deficiency causing hyponatremia. Are you guys with me? Coming to the next cause, that is the cause which causes hypovolemic hyponatremia, that is cerebral salt wasting. I guess all of us are aware about this condition, especially with the patients with neurological diseases, right? It is usually seen in patients with subarachnoid hemorrhages that is usually associated with hypovolemic hyponatremia. It is characterized by renal salt wasting. The exact mechanism is still a mystery. It can be because of the non-osmotic release of ADH, or it was because of the release of atrial or a brain natriuretic peptide. The problem with this is most often this is overdiagnosed. Okay, so more often, whenever you have a case in the ICU with the CNS problem, the case would be SIADH rather than cerebral salt wasting. What we need to understand this cerebral salt wasting, the condition, the patient would be hypovolemic. The patient will have a gross deficit of volume. Okay, so that is what we need to understand. If the patient is euvolemic, which is mostly the case in an ICU patient, it is probably SIADH as compared to cerebral salt wasting. Okay, so how do we come to an understanding of cerebral salt wasting? Usually, as in the case of SAH or any brain trauma, there will be a neurological event, correct? That causes secretion of probably ANP or BNP, which usually affects the juxtaglomerular apparatus, and because of which there is a loss of sympathetic tone. I'll be telling in detail about this in the further slide. Okay, so because of this, there is sodium loss from the tubules, and this causes effective volume in the body to be dropped. Okay, that is the intravascular volume is dropped because there is some natriuresis that causes diuresis and then causes hypovolemia. When there is hypovolemia, ADH is secreted. ADH again goes in, causes water reabsorption, and then the water reabsorption in this particular case, if not corrected up to the par, leads to subclinical volume expansion and thereby causing drop in sodium because there is natriuresis. There is the imbalance between the activation of natriuresis and ADH. Okay, so the labs usually show a low sodium value, low serum osmolarity, high urinary osmolarity, usually more than 100 milliosmoles per kg, sometimes more than 300. And what is something that we need to notice, these patients also have low serum uric acid. Uric acid is also actually removed in the urine. So the treatment usually is supplementation of isotonic saline. I told you hypovolemia is the driver here. So hypovolemia should be corrected so that the vicious cycle is offset and sodium status is restored. So whenever you have a patient with hypotension, decreased skin turgor, increased hematocrit, and with the urine sodium being more than 40 milliequivalents per liter, think about probable cerebral salt wasting. For such patients, management, instead of giving sodium solutions, we just give them isotonic saline. That should be normalized. Okay, so this should help. So coming to euvolemic hyponatremia, till now we were talking about hypovolemic hyponatremia. So coming to euvolemic hyponatremia, the most common type of hyponatremia in the hospital is euvolemia. That is euvolemic hyponatremia. Whenever there is a urinary sodium more than 20 milliequivalents per deciliter, you should think about that. Most of the cases will have this. It's the problem is usually with the kidneys in euvolemic hyponatremia. What usually happens is, despite water retention, there is no edema in these patients. That is because the fluid is going and getting sequestrated in the cells. That is, cellular swelling usually happens. And this is usually seen in two disorders. That is hypothyroidism and secondary adrenal insufficiency. That is commonly due to either hypothalamic or a pituitary disease. So this is usually because there is an impaired RAS pathway or there is an impaired ADH pathway. Okay, the whole trigger in euvolemic hyponatremia is the drop in the effective intravascular volume. So in euvolemic hyponatremia, first thing that we need to do is assess whether the patient is hypothyroid or not. Check for adrenal insufficiency, especially the glucocorticoid deficiency. Problem is these patients have secondary problems. That is, there is a hypothalamic or pituitary insufficiency. The ACTH might not be producing properly. So because of which they will have secondary features. We should also, in the meanwhile, check for stressors that can cause SIADH, be it infection, pulmonary, extrapulmonary, tumors, drugs, etc. Okay. As compared to primary adrenal deficiency, there is both decreased cortisol because there is no stimulus, as well as there is no secretion of the stimulating agent here. So understanding the RAS pathway, we spoke about this in the cerebral salt wasting. I'll also be in detail speaking about it here. So bear in mind, and please bear with me. It will be a little lengthier. I know we all know this, but let's go in a stepwise format. So whenever there is dehydration causing sodium deficiency, it can be associated with a drop in blood volume, or it can be associated with drop in blood pressure. So this is usually sensed by the juxtaglomerular cells in the kidney. So what they usually do is they secrete renin. Okay. Along with this, the liver also senses that there is a drop in effective blood volume circulation, and that also produces angiotensinogen. So both renin and angiotensinogen combinedly get active. They secreted in the circulation. The angiotensinogen gets converted to the active form, that is the angiotensin 2. And these actually in turn go and stimulate the adrenal cortex. Okay, so angiotensin goes and acts both on the adrenal cortex, also acts on the arterioles. Okay, so when it stimulates the adrenal cortex, there is another pathway that is stimulated. The adrenal cortex usually produces aldosterone. So this aldosterone is the one which acts on the kidneys and causes increased sodium and water reabsorption and increased secretion of potassium and acids into the urine. And because of absorption of sodium and water, increased reabsorption, there is reconstitution, or else the restoration of the blood volume, which happens, and that normalizes the blood pressure. Okay, so this is the usual RAS pathway which has to be there. If one of this is missed, this can cause hyponatremia. In this case, what we need to understand is adrenal cortex being the problem. That is, aldosterone will not be getting secreted because there will be insufficient input from the pituitary. Okay, this can cause decreased activation of aldosterone, leading to decreased sodium and water reabsorption, thereby worsening the hyponatremia. So what are the drugs causing hyponatremia, especially in euvolemic? You can remember with the mnemonic as Crrt, chemotherapeutic agents, antidepressants and antipsychotics, or anti-inflammatory, especially the COX inhibitors, recreational drugs like ecstasy, diuretics. But you need to remember diuretics usually is hypovolemic hyponatremia. Okay, this is one exception that I want you to remember. Rest are usually euvolemic. Okay, inhibitors of the RAS pathway, sulfonylureas, and hormones like oxytocin and desmopressin. So these are the drugs usually that are associated with hyponatremia. Okay. Coming to SIADH, SIADH, as we all know, is the syndrome of inappropriate ADH release. What usually happens is water resorption. There is no concentration of urine, and there is reduced urine volume, and thereby causing water retention, and that causes drop in sodium. Okay, so this happens because this is usually due to the hypovolemic hyponatremia. So coming to the diagnosis of SIADH, Barter and Schwartz criteria is the one which we usually used for the diagnosis of SIADH. It is described by the serum osmolarity less than 275 milliosmoles per kg, increased urinary osmolarity of more than 100, presence of euvolemia. That is something that we need to know. Always in a case of SIADH, it is euvolemia, whereas in a case of cerebral salt wasting, it is hypovolemia. Okay. No other causes of hyponatremia, especially diuretic use or cortisol deficiency or hypothyroidism, should be present when we are making a diagnosis of SIADH. If there are paraproteinemias, cortisol deficiency, hypothyroidism, probably that is the cause. Okay, so this is always a diagnosis of exclusion. Okay, so we need to remember these things. Just a minute, I think so I made an error mentioning it as hypovolemic. Okay, it is euvolemic hyponatremia. Please excuse the error here. So any doubts still here? Okay. Going ahead, causes of SIADH, they are actually classified into multiple ways. Okay, so what I need you to understand is Neurological are the most commonly the things which are associated with SIADH. So start with neurological causes, be it hemorrhages, especially subarachnoid hemorrhage or a subdural hemorrhage, or syndromes like autoimmune diseases like Guillain-Barré syndrome. Infective etiologies can range from meningitis, encephalitis, lung abscess, pneumonias, etc. Respiratory disorders like tuberculosis, asthma, probable viral pneumonias. Medications, as I've already mentioned to you, remember the mnemonic as mentioned earlier. Okay, antidepressants, anticonvulsant, antipsychotics, recreational drugs, etc. Malignancy, it can range from lung malignancies, pancreatic malignancies, gastrointestinal malignancies, or hematological malignancies. Any of this can cause SIADH. And non-ADH antidiuretic peptide release can happen in Waldenstrom macroglobulinemia and prolactinoma as well. Okay. So remember a few things. This is what I have always been stressing. Just categorize the causes. Whenever they ask causes, just categorize them and give it. Okay. So coming to the treatment of SIADH, as I've already mentioned, it is a euvolemic hyponatremia. It's a diagnosis of exclusion. Make sure that your cortisol levels are normal. There is no hypothyroidism. There is no paraproteinemias or, as I mentioned earlier, pseudo hyponatremia should be ruled out as well. Then you will have a confirmation of SIADH based on decreased serum osmolarity, increased urinary osmolarity, and increased urinary sodium, that is more than 20. Okay, so if you have these things, that confirms the diagnosis of SIADH. With that, the next steps is usually general. That is, for any patient who comes with hyponatremia, we have to look in whether they are symptomatic or asymptomatic. If they're asymptomatic, probably in this case, because it's a euvolemic hyponatremia, fluid restriction, that is roughly around 1 to 1.2 liters per day, should help correct the hyponatremia. If the patient is symptomatic, then we need to again think whether it is acute and chronic. Based on the acuity of the event, we need to manage them further on, which I'll be explaining in the further slides. Okay. So coming to the major differences between SIADH and cerebral salt wasting. SIADH, usually we know both are associated with decreased serum sodium. In SIADH, the most important thing I need you to remember is that patients are euvolemic, whereas in cerebral salt wasting, because of the activation of natriuresis, there will be hypovolemia. Okay, so these patients are hypovolemic in cerebral salt wasting syndrome. The urinary sodium is usually more as compared to SIADH in cerebral salt wasting. Cerebral salt wasting, like I mentioned, it is usually more than 40, but SIADH 20 to 40, depends on what is the volume status in these patients. Urinary volume can be normal or decrease in SIADH, but urinary volume will be more in cerebral salt wasting because of natriuresis. I also mentioned earlier, the serum urates can also add on to this. Sometimes it can be normal in cerebral salt wasting, but usually in SIADH it is dropping. Okay, urinary urate is increased in both these conditions. The most important thing is something that you need to notice here is the volume, that is euvolemia and SIDH, cerebral salt wasting, it is hypovolemia. The urinary volume as SIDH can be normal or decreased, but in cerebral salt wasting, urinary volume will be high. Okay, this is something that you need to keep in mind. Sometimes when you have patients in the ICU, you can see there is higher urinary volume and then the patient can still have mild hyponatremia. Probably the patient first rule out if the patient is on hypertonic saline. Okay, so that can be falsely high. So calculate your urinary osmolarity at that point. If you have a patient on hypertonic saline, that will become translocational hyponatremia. Okay, this is one of the things that we tend to overthink and diagnose as cerebral salt wasting. I was telling you earlier as well, cerebral salt wasting is something like an overdiagnosis most of the times. So if we go through the algorithm properly, first check the osmolarity, then know the tonicity, rule out pseudo or translocational hyponatremia, then establish the volume status, and then go about the diagnosis of hyponatremia, will not make any mistakes. But if we skip any of these steps, then we might end up misdiagnosing or overdiagnosing the case. Okay. So coming to the approach of hyponatremia in general, Hyponatremia usually can be classified as acute or chronic hyponatremia. If at all the symptoms arises less than 48 hours, it is classified as acute. Usually it is more severe. And the symptoms associated with acute hyponatremia are seizures, coma, brainstem herniation, sometimes can be catastrophic, leading to death. Whereas chronic hyponatremia is usually present when it is of more than 48 hours of duration. It tends to be less severe because some amount of adaptation starts occurring in the body, usually associated with symptoms like headache, nausea, vomiting, lethargy, and weakness. So these are the steps that we need to go about: volume status and severity, okay, whether it is acute or chronic. Measure both the serum as urinary osmolarity, send in TSH and cortisol levels. Measure serum spot sodium. You can also send in spot potassium. That can help us understanding if there is any diuretic abuse, like I've mentioned earlier. Obtain chest X-rays, ABGs, other labs, with usually they help you narrow down the causes. Always remember ABCs are first, optimize the patient's airway, breathing, and circulation. Probably at that point in time, don't think of restricting fluids if the patient is actually having low GCS with hypotension. Probably you need to give them fluids, and then we can de-resuscitate if necessary. Optimize hemodynamics and follow up all the lab investigations. So one of the things that I need you guys to have a look at is, this is one of the questions which they usually ask in the practical point. So is there a method by which you can falsely, estimate low serum sodium values? Earlier in the day, they used to use something called as flame photometry. Okay, so probably it was one of the crude methods which they used in biochemistry to check the presence of or the quantity of sodium. So what used to happen is it used to measure both the aqueous and the non-aqueous part of plasma, thereby attributing to the presence of triglycerides and proteins as well. So whenever these were taken into consideration, there used to be a false estimation of sodium, leading to false hyponatremia or else pseudo hyponatremia. Okay, so right now this has been offset. Most of the labs which are NABL certified, they usually have something called as the ion specific electrode method, which is used to measure the sodium value. So this is one practical point I want you guys to remember. In Viva, they usually tend to ask this question. Yeah. So coming to the practical aspect again. So what is the rate at which we need to correct hyponatremia? Why is rapid correction avoided in hyponatremia? Why does osmotic demyelination syndrome occur? Anyone wants to answer this? Okay, one by one. Question number one. What's the rate?
Rate is to 6 to 10 milliequivalent in 24 hours.
Great, very good.
Rapid correction is avoided to avoid this osmotic demyelination syndrome.
I'm sorry, that was quite inaudible. Can you repeat that, please?
Sorry?
The second answer, can you repeat it, please?
To avoid, sir, this osmotic demyelination syndrome.
Okay. So why does it cause osmotic demyelination?
Because it's a rapid shift in this oncotic pressure between the intracellular and extracellular compartment.
Okay. What happens then? Okay, what is the cerebral adaptation that happens when there is hyponatremia? Okay, I'll come about that. Okay, so usually whenever there is hyponatremia, the immediate effect, usually the body is actually a very nice system. It tends to maintain homeostasis. Okay, so the immediate effect of hypotonic status, the volume gain which is present there. Okay, so the water is usually pushed across from the intracellular space to the extracellular space. The brain cells try to remove osmoles from them to outside the extracellular space so that the cellular swelling does not happen. Okay, so this prevents osmotic demyelination, especially in the earlier stage, 3 hours of hyponatremia setting in. So whenever there is decrease in extracellular fluid osmolarity, a cell swelling is supposed to happen. Okay, but that is usually because of the gradient shift. And this causes raise in intracranial volume that leads to tissue edema. Okay, So because of this tissue edema in the cranium, that can lead to raised ICP and sometimes leading to herniation, etc. Okay. Along with this, it can cause osmotic demyelination because the cells start to tend losing ions. Okay, especially the ones which are required for neural monitoring or neural communications. Okay. So what is the usual volume regulatory response which tends to be present is cerebral ECF is shunted to the CSF. That is the systemic circulation. That is what happens, okay? The ECF volume is pushed into the cerebral spinal fluid. That's cerebral spinal fluid by circulation pushes into the systemic circulation. To avoid cell swelling, what the brain again does it is to, it adapts by pushing out potassium and other solutes in the neurons, okay? Even if this is unable to maintain the volume status in the cell, what it does it actually starts losing other ions like uh, myoinositol and amino acids like glutamine and taurine and phosphocreatinine. Okay, so these are the things which the brain actually tries to adapt in the initial phases. In these, if the brain is unable to do this, if at this time, if it is in the adaptation phase and we rapidly infuse sodium at the same stage, the brain gets confused. Okay, and because of which there will be sudden swelling of the brain cells which happen. That is, the neuron swelling happens, and that leads to osmotic demyelination. Are you guys with me, or do you want me to explain it again? All that you need to remember is in the first 2 to 3 hours or in the first acute phase, okay? Always remember in acute hyponatremia, that is less than 48 hours, the patient is having a drop in serum sodium. The body tries to adapt. The most important adaptation which is happening is in the brain. Decreased in extracellular fluid osmolarity usually causes cell swelling, okay? That is because extracellular fluid, this sodium is low. By and large, the intracellular fluid, that is the cell, usually have higher concentration of solutes at that time, correct? So water tends to enter the cell, because of which the cell can swell up, right? So this is again offset by the neuron by doing what? It tries to push out electrolytes into the circulation to prevent the cell from, that is, the neurons will prevent itself from getting swollen up. But if it is unable to do that also, what it starts doing it, along with electrolytes, other amino acids and proteins are also being lost. Okay, so this is usually up to 3 hours of the first initial adaptation period. In this period, okay, the patients are usually bound to have some amount of severe CNS symptoms. Because of cell swelling, they can have seizures. Because of cell swelling, they can have some amount of bleeding, and they can have, drop in sensorium. Okay, along with these things, if you give sodium in a increased correction in this particular time period, this can again suddenly cause a change between the ECF and the ICF compartment, leading to the occurrence of osmotic demyelination. Is it okay?
So would edema cause osmotic demyelination due to
It's
increased extracellular fluid volume?
No, it's usually not the edema causing it. It's the fluctuation of serum sodium. So we always have attributed correction of hyponatremia to ODS, that is osmotic demyelination. If you look into the literature clearly, right, even sudden correction of excess hypernatremia, has been associated with osmotic demyelination. It does not mean that you're increasing sodium, only then osmotic demyelination happens. It is the fluctuation of sodium which causes osmotic demyelination. Coming to your question specifically, whether swelling causes demyelination, it's not swelling alone. Yes, if the swelling goes beyond the capacity of the neuron to maintain basement membrane integrity, yes, that leads to demyelination. Hope I'm clear.
Yes, sir. Thank you.
Okay, it's the fluctuation which we need to know. If someone asks you whether only correction of hyponatremia causes osmotic demyelination, the answer is no. Even overcorrection of hypernatremia has also been associated with osmotic demyelination syndrome. Okay. So coming to the patients who are prone to ODS, they are usually elderly. Elderly females have a more predilection to that. Patients who are on chronic diuretic use, alcoholics, burns victim. So usually these patients are the ones which are volume depleted, right? So these patients are the ones who are prone to develop osmotic demyelination syndrome. Okay. So how do we initiate correction? So always remember to characterize them between acute and chronic. If it is acute, start rapid monitored correction. Okay. Always remember, in acute only we need to do rapid correction. Chronic, usually you start assessing the volume status, volume correction, and then probably sodium supplementation. Okay. What do I mean by rapid monitored correction? In acute symptomatic hyponatremia that occurs less than 48 hours, if the patient has any CNS symptoms, okay, unless the symptoms are relieved, we can give a bolus of hypertonic saline in such patients. And usually what we target is a raise in serum sodium by 2 millimoles per liter per hour. Okay. The ones which they have told us, you can use a 3% saline solution of 2 ml per kg bolus over 5 to 10 minutes intervals. And you should monitor the serum sodium closely, roughly about 4 hours. Okay. So you should avoid it going beyond 8 to 10 milliequivalents per day. That is the whole idea. So this is one of the articles which I've picked up. There are multiple things that have referred to the cutoff values and the instances where we can give. PAC didn't give us anything in detail. I was hoping PAC would do that. But yeah, when I remember that we should only give it as 1 or 2 boluses. But here I got an article which actually said that you can up to, go up to 3 boluses till the symptoms are relieved. So what they have suggested is, if there is a patient with severe symptoms, that is decreased consciousness, seizures, or muscle rigidity, you can give a bolus of 2 ml per kg of hypertonic saline. Observe the patient over the 5 to 10 minutes. Repeat the boluses as necessary. You need to give the boluses until the patient's symptoms are better. Okay, or else if they are relieved. In this time, if the patient's neurological status starts improving with 1 or 2 boluses itself, then you can go back to the no severe symptoms column that is onto the right side, and then plan a conservative goal, that is to reach 8 millimoles per liter in 24 hours, or 14 millimoles per liter in 48 hours, and 16 millimoles per liter in 72 hours. Okay. So this is usually what is taken into consideration. If at all we are unable to get this, if you get mild improvement and then we are stuck up with these things, then you need to monitor these patients as to optimize the volume status. Probably along with this, we need to give the patient a diuretic. If despite this, the patient doesn't improve, probably on day 2, you can even think about the use of desmopressin. Okay. So coming to the determination of volume status and the this thing, we usually use the Andromedia's equation, but Andromedia's equation usually for hyponatremia, it's less likely, but usually we use it for hypernatremia. Okay. So in this, we always know there is a goal that we need to achieve, and based on that goal, we need to go ahead with it. Okay. Coming to chronic asymptomatic hyponatremia, evaluate the cause, rule out hypothyroidism or pituitary insufficiency, check the serum cortisol levels and volume status. In chronic hyponatremia, the 4 pillars of treatment usually are fluid restriction, use of vasopressin antagonist or vaptins, diuretic solute excretions. That is what we need to think about. Okay. Along with that, you need to think about other pharmacological agents which are usually less likely used in the current scenario, like dimethylcycline and lithium. Coming to fluid restriction, mostly importantly, we need to think about SIADH. SIADH is one condition which is associated with chronic hyponatremia. You might be seeing these patients coming to you time in and time out. So usually avoid hypotonic solutions, monitor the response to diuretic in such patients, monitor serum sodium values based on osmolarity, that is both serum as well as urine. Okay. Whatever you do, always check for the response. Okay. If you see that the sum of the urinary sodium and urinary potassium is more than the serum sodium, water restriction alone might not be sufficient. So usually along with water restriction, you need to give some supplementation of sodium to these patients. In these patients of SIADH, you should know that urinary osmoles are usually they are fixed because of the ADH action. Okay, the osmolarity doesn't go more than 600 millimoles per liter. Especially the sodium handling in SIADH is altered. In SIADH, more likely we will never ask the patient to be supplemented with this thing, rapid correction of sodium. Okay, only that thing which is required for these patients is fluid restriction. Coming to the understanding of the use of vaptins, okay, vaptins are usually AVP antagonists, right? Arginine vasopressin is the one which is secreted by the posterior pituitary or the neurohypophysis. That is usually due to a stimulus because of decreased intravascular volume or increased plasma osmolality. So AVP usually acts on multiple receptors. They are classified into V1 and V2 receptors. V1 receptor is again classified as V1A and V1B. So V1A and V1B, usually the V1 receptors are associated with regulation of vascular tone, whereas V2 receptors are usually present in the kidneys and regulate both water and sodium reabsorption in the kidney. Okay. So V2 receptors are present in the collecting ducts. That is supposed to be understood. Okay. What usually happens after the neurohypophysis secretes vasopressin is it acts onto the V2 receptors. We are only confining ourselves to the kidneys right now, which causes the presentation of cyclic AMP, and that causes an expression of a channel that is called as the aquaporin channel, that is aquaporin 2 and aquaporin 3. This causes the insertion into the cell membrane. Okay, because of the translocation of these porin channels, it causes the increased driving force of water reabsorption with water flow into the collecting duct. What usually happens is, if this is the nephron, this is the luminal surface, this is the basolateral surface. Okay. Whenever there is an aquaporin channel which is present in the basolateral surface and there is no ADH present, the aquaporin channels are usually present inside the cell. Okay. So the V2 receptors are present here. What happens when there is presence of ADH? So this causes translocation of the aquaporin channels to the luminal surface, because of which you can see this water. Here there is no movement, right? So you can see here there is movement of the water into the basolateral surface, and then it can get reabsorbed. Okay, so this is how arginine vasopressin causes the activation or retention of water into the body. Okay, so this is something that we need to block. By blocking this, we can cause a drop, correction of hyponatremia in these patients. That is euvolemic hyponatremic patients. Okay. So the ideal therapy, which was focused for the use of vaptins, is aquaresis. So this is what you need to understand. What does aquaresis mean? There is water excretion, but there is no electrolyte excretion. That is, both sodium and potassium are unaffected. So the term used is aquaresis. Okay. Prompt but safe correction usually appears between 24 to 48 hours. The thing which you need to check is up to 12 milliequivalents per liter happens in 24 hours and 18 milliequivalents in the 48 hours. Usually these are associated, the use of vaptins are predictable and reliable, and they have a sustained titrable effect, which is being proven by multiple studies, which I'm going to mention in the later slides. So these are the things which they have mentioned. Okay, they are effective and safe. They do not cause excessive hyponatremia or any other sort of dyselectrolytemia. This actually gives them a better standing as compared to diuretics, because diuretics are usually associated with dyselectrolytemia. So the usual drugs which are present in the market are tolvaptan, lixivaptan, satavaptan, and conivaptan. What you need to know is tolvaptan, the advantage is it's being oral drug, whereas conivaptan is IV. I particularly haven't used conivaptan. I don't know if it is available. Lixi and satavaptan are not available in India. So the mechanism of action is tolvaptan acts on V2 receptors. The route of administration is oral. It causes decrease in urinary volume and urinary osmolality is dropped. Okay, the sodium excretion does not change. That is what you need to understand. So the vaptins are usually used for treatment in significant hypervolemic or euvolemic hyponatremia. So you can use it both in hypervolemic patients as well as euvolemic patients, especially in patients with cardiac failure, cirrhosis, SIADH. It has also been shown that patients with chronic kidney disease not on dialysis, the morbidity associated with volume status, especially due to retention of sodium, has been actually better tolerated with patients on vaptins. The initiation of dialysis has been postponed because of use of vaptins in such cases. So Vaptans are contraindicated in the following conditions: urgent need to raise serum sodium acutely. If at all the patient is symptomatic with seizures or drops sensorium, we cannot use Vaptans. If the patient is unable to respond to thirst, that is something that the patient has a CNS problem. So if they are having some issues, probably it is unlikely that it will function properly. In patients with hypovolemic hyponatremia, it's absolute no-no. Concomitant use of CYP3A inhibitors can usually cause an increase in the drug levels, thereby the efficacy of those drugs can be affected. So patients with anuria, definitely this does not work because the principle is aqueresis. Okay. So coming to multiple trials, SALT-1 and SALT-2 trials were the ones which have been studied for the use of Vaptans. Both showed significant benefits with the use of Vaptans in SIADH. So when they compare it with the placebo, tolvaptan actually did better, okay, especially on day 4 and day 30. If you can see this graph here. On day 30, Vaptans increased sodium concentration by 7.4 millimeters as compared to 1.5 milliequivalents per liter. So these trials actually have proven that the use of Vaptans, especially in hypervolemic and euvolemic patients, have a better outcome in normalizing sodium values. Coming to another concept called as reset osmostat. So I spoke to you about cerebral adaptation. I spoke to you about the initial slide about physiology of sodium balance. So always there is some osmocenter present in the brain. Always there is a thirst center present in the brain. And there is the neurohypophysis also. All these things are interrelated. So whenever the patient feels that, there is hypernatremia or the osmolarity is going up, the patient should feel thirsty and the patient should drink water. That is because the subphonical organ or the osmoregulatory center in the brain senses that the concentration of sodium is high and the volume of water in the body is low, and that's the thirst center activates and the patient should drink water. Same way, if the volume is very high, if the patient's sodium value comes down, it means to say there is excess of water in the body. Probably at that point in time, it has to regulate antidiuretic hormone. And then by the means of that, either should help in loss of water or it can help in retaining sodium and water in the body. Okay, so this is how usually the brain should work. But what usually happens is in 20 to 30% of cases of SIADH, this threshold is altered. Okay. The patient remains asymptomatic even with hyponatremia. This is actually a subset of SIADH, that is reset osmostat. This is actually more likely as a theoretical concept. Still, the overall outcome, the factuality of this is not to be totally understood. So whenever we have a patient with SIADH and they're not responding to something like a fluid restriction or any other modality, then we need to think about the patient of having a reset osmostat. Okay, so this is one of the diagnostic criteria for reset osmostat. The patient usually has a normal serum value with a low serum sodium that maintain a sodium balance without correction in hyponatremia when salt was initiated. That is, whenever the patient was having hyponatremia, water restriction, sodium supplementation, or steroid supplementation like fludrocortisone did not affect the correction factor. That is, hyponatremia persisted in these patients. Only response was with the use of Vaptans. So if the patient is only responding to Vaptans, but there is no effect on water restriction, sodium supplementation, and fludrocortisone, probably there is an alteration in the physiology, and that is understood by the concept of reset osmostat. Okay, this is more something like a factual or a controversial thing. Just remember, this might be asked in your Viva. If they ask you, just tell that reset osmostat is a subset of SIADH, wherein it does not respond to water restrictions, sodium supplementation, or fludrocortisone, which are usually the pillars of approach in SIADH. But the only positive response noted in reset osmostat is for the use of Vaptan. Okay, this is how you can summarize if someone asks you about reset osmostat. So coming to the summary of management of hyponatremia, firstly, know the serum osmolarity, then know the extracellular fluid status, then classify whether it is pseudo hyponatremia if it is isotonic. If it is hypertonic, rule out the presence of hyperglycemia or use of hypertonic saline at that particular time. If it is not translocational hyponatremia or pseudo hyponatremia, then consider this patient to have true hyponatremia, that is hypoosmolar hyponatremia. Okay, if the patient has hypoosmolar hyponatremia, by clinical assessment of the extracellular fluid, know whether the patient is having euvolemia, hypovolemia, or hypervolemia. Hypervolemia usually is associated with congestive cardiac failure, cirrhosis, or probably a nephrotic syndrome pathology. Usually, if this is the condition, the urinary sodium will help you understand it better. If the urinary sodium is less than 10, probably it's one of these causes. But if you have a hypervolemic patient with urinary sodium more than 20, look at the creatinine value. Probably this patient can have an acute kidney injury or a chronic kidney disease. In the same way, if the patient is having hypovolemic hyponatremia, this can either be because of two reasons. That can be either because of a renal cause or an extra-renal cause. Okay. If it is hypovolemic hyponatremia and the cause is renal, look for the urinary sodium. If the urinary sodium is more than 20, then the causes usually would be because of use of diuretic, mineralocorticoid deficiency, or salt-losing nephropathy. One of these things, are probably even osmotic diuresis. If the urinary sodium in hypovolemic hyponatremia is less than 10, that is urinary sodium less than 10, probably it is an extrarenal cause. The cause usually may be due to diarrhea or vomiting, that is the GI causes, or third spacing causes like in cases of burns, pancreatitis, okay, or even in case of trauma. Coming to the most important cause, that is euvolemic hyponatremia. What usually happens here is the urinary sodium value is more than 20. The most common cause here would be because of SIADH. Other causes usually associated are drugs other than diuretics, glucocorticoid deficiency, and hypothyroidism. Okay, so if it is because of these three things, we need to classify these people as being euvolemic hyponatremia. This is usually the broad understanding of the causes of hyponatremia. Coming to management, always understand the management is based on the acuity and severity. If it is acute, that is less than 48 hours, and the patient is symptomatic with the severe symptoms being seizure, low GCS, or hemodynamic compromise, this warrants for bolus of hypertonic saline. Multiple boluses in a span of 5 to 10 minutes can be given. The correction factor usually is around 2 millimoles per liter. And when you need to stop it? When the symptoms resolve, okay? Don't target at an excessive correction. Usually the targeted level is 8 to 10 millimoles per day or milliequivalents per day. So this is usually what we need to do in a case of severe event. Despite this, if you're unable to correct it, you might need to think about other drugs, especially the use of diuretics. So you can use diuretics in such cases of euvolemic hyponatremia to see if it is getting corrected. If it doesn't get corrected, you can also use desmopressin. Coming to the management of SIADH. SIADH is another cause of this one, euvolemic hyponatremia. You have to rule out a lot of things. The patient should not be hypothyroid. The patient should not have cortisol deficiency. The patient should not be having any diuretic-induced hyponatremia. Having fulfilled these criteria and the urinary sodium being more than 20, and probably one of the causes of SIADH, be it infective or non-infective, causing hyponatremia, then you need to use the pillar approach, that is fluid restriction, which is the mainstay, because the cause of hyponatremia in SIADH is usually a chronic hyponatremia. Okay, so usually you have to start with fluid restriction, usually up to 1.2 liters per day. Along with this, if you feel that the patient is having some mild symptoms or the patient is prone to SIADH, especially if there are high-risk candidates, you can use Vaptans in earlier stage. But always watch for issues like urine output. If the patient is anuric, please don't use Vaptins. Okay, that can be counterproductive. If at all your patient fits into a category of having congestive cardiac failure, or a patient with cirrhosis with hypervolemic symptoms, then you can still think of using Vaptins because it uses aquaresis. Okay, so along with this, we can also use other drugs like solute removal, which can be the use of a thiazide diuretic. Along with that, you can also think about using demeclocycline or lithium, which is usually not used because they're associated with neural symptoms. So this is by and large the monitoring and management of hyponatremia in the ICU. Any questions?
Sir, could you please explain again the difference between tonicity and osmolality?
Okay, great. So remember one thing, whenever you talk about, you imagine that you have two cups with you, okay? So in one cup, you have same amount of sodium, potassium chloride, and say some other electrolyte like phosphorus, okay? They're all osmotically active molecules. In the other cup, along with the same things which I mentioned to you earlier, you have to add in some osmotically inactive ions, okay? So in this case, I will take in like something like a urea, okay, or a glycine, something like that, okay? So what happens here? Do you think both the concentration of electrolytes are same in both the things, both the cups? Which is more denser, which is more viscous?
So the first cup.
The first cup has a lot of electrolytes. The second cup has a lot of
Lot of
molecules,
other.
right? Yeah. So one thing is whenever we talk about osmolarity and tonicity, right? Remember, one is about osmotically active molecules. That is osmolarity. Okay. Tonicity refers to all the molecules which are present in the solution. It can be osmotically active or it can be osmotically inactive. It accounts for all the molecules or solutes present in the solution. Okay. That is one simple understanding. Still confused?
So I understood, sir.
Okay, so for example,
Basically,
you just remember one thing, okay? Remember the SI unit of osmolarity and tonicity. Okay, the tonicity's SI unit is moles per liter. Okay, so when I'm rating it as moles per liter, it refers to all the solutes which are present in the solution. It does not distinguish between whether they are osmotically active or inactive. Okay, whereas whenever you take as osmolarity, it usually refers to milliosmoles or osmoles per liter, correct? So that refers to only osmotically active molecules. And osmolarity is usually, the movement based on osmosis and a semi-permeable membrane. Okay. Whereas tonicity, it usually is the pressure gradient between two compartments. It can be ECF, ICF, okay, or ICF with ECF, one of those things.
that means by tonicity, the molecules can also pass freely through the
Correct.
through the ECF and
Correct.
ICF.
Use
Okay.
water. Understand by you understand tonicity by the movement of water. Okay.
Okay.
Water can usually freely move across any of these compartments. Yes.
Okay. Thank you, sir.
Okay. Okay. It's actually, when we talk about this, it's a little confusing, tonicity versus osmolarity. If you by and large see the definition, right? So what they ask us to do is drop the urea. Like when we measure osmolarity, they say it's 2 times this sodium, glucose by 18 plus, urea divided by 2.8. But if they say calculate tonicity, right, they usually drop in the urea. Okay. For gross understanding, you can think that that is actually the valid calculation for tonicity of a solution. Okay. Any other doubts? Okay. I think so. Next, we'll continue with the remaining topics on metabolic alkalosis and one of the other electrolytemias as well. So I'm actually going to remind you guys again that we are going to do the class on renal replacement therapy tomorrow, probably in the evening. We'll again share you the details of the class shortly. Okay. And for the people who have joined in later, you still have a week's time, guys. Please, try and attempt your mock questions by next week. We are planning to do the mock debrief we are actually ready with the debrief. We are just hoping that few more people, attend this. So that is one of the reasons. Okay. Okay. Bhagishri, are you there?
Yes, sir.
Okay. I think so. We can start the next one. Okay.
So please confirm once the voice is audible to you.
Yes, sure.
So the voice is audible.
No, I'm not, and I'm not able to hear it.
The recording voice is not audible.
No, no.
Once I will listen.
Yeah. I think so. The slides are not moving. I think so. Once it starts going ahead. It stopped, I think so. It stopped at 13 seconds. Play that. I'm sorry, I'm unable to hear anything. Just check the volume. Yeah.
You are unable to hear the sound.
No. I can't hear anything.
Okay, sir. Now it's audible.
Yeah, it's audible, but it's very low. Can you increase the volume a bit?
So this is the highest volume of
Maximum,
the
is it?
DJ.
Okay.
Can I play it,
This-
sir? Because this
Yeah,
is
yeah,
the
play
highest
it,
volume.
play it, will. Let's see.
Okay, sir.
So coming to the etiology, because of intracellular cysts of hydrogen, which is commonly associated with the
Yeah,
hypokalemia.
okay, good.
What happens is that potassium so the next topic for discussion was on metabolic acidosis.
Sir, your voice is too low, sir.
Introduction to etiology and management. Now, this topic
Excuse
is
me.
important both from a theory perspective.
Sir, sir, your voice is too low.
Perspective.
Can't hear
So,
much.
we need to know
Sorry.
Voice is
Paritosh,
too.
it's a recorded class actually. If you're unable to hear, let us know after some time. If it's too low, we will forward it to the next topic.
Bhageshri, go to some other time, like go to up to 3-4 minutes. Just see if the voice is audible. Otherwise, we have to.
Mm.
Okay, sir. Okay.
Sorry, sir. Unable to hear you.
No,
Try to
just
play.
scroll it a little more.
Can you guys see the screen all right? And hear me all right?
Sir, your voice is audible, sir.
Voice is audible?
Yes, sir.
Okay. Right. Today we'll be talking about renal replacement therapy. I will start with just the. Sorry, give me one sec. All right. I'll start with the basic principle, and I think the speaker after me will be talking about the more nitty-gritty of the renal replacement therapy. Let me know if you find any issue with my sound or the slides not working. Lately, this has been an issue with the Zoom. I don't know what's happening once in a while. Okay. All right. So basically, why we talk about kidneys a lot? Because the kidneys are the most important organ in the body in the perspective of an intensive care physician. Because everything narrows down to kidney, and then the patient would have a bad outcome in any of the disease you can think of in ICU. whether it is sepsis, whether it is pancreatitis, whether it is trauma, whether it is any other, like a cardiac arrest or anything. So kidney are the most sensitive organ in the body that gets hampered and damaged by any insult to the body. And take any system or any organ, that ultimately that the pathway for death is through kidney. And because it does a lot of things, like starting from managing the internal milieu of the body to production of substances to clearance of substances, it is the final pathway for most of the pathophysiology of any organ you can think of. So that's the basic reason why we think of kidneys very, very importantly. For example, if you look at a toxin or any sort of autoimmune disease or any other injury to the body, that ultimately narrows down to a kidney injury, causing disturbance of the internal milieu, acidemia, uremia, hyperkalemia, fluid overload, etc. Lots of problem, and then ultimately leads to bad outcome of a patient. So that's why we think of this system as the most important one. Now, how does RRT help? In general, RRT has many different modality or submodality. We talk about intermittent hemodialysis. We talk about sorry, just give me 1 second. Intermittent hemodialysis. We talk about continuous renal replacement therapy. We talk about SLED. We talk about other
Sir,
modalities.
can you be a little louder, please?
Sorry.
थोड़ा सा loud
Okay.
volume बढ़ा सकते हैं?
Give me 1 sec. I will try to put you on the headphone if that helps. Can you guys hear me better now?
Yes, sir. Yes, sir.
Is it better?
Much better, sir.
Okay,
Much
that's
better,
good.
sir.
That's good. That's good. Give me only 1 sec. Give me. All right. Is the sound all right now?
Yes, sir.
Okay. All right. So as we're talking about, there are many modalities of renal replacement therapy that we work on based on what sort of pathology the patient is experiencing. We choose one modality, or based on the resources that we have, we choose one modality, or based on what's the end outcome of a treatment we aim at. So there are multiple treatment aims for renal replacement therapy, starting from supporting the kidney, clearance of substances, clearance of fluid, etc., etc. Based on that, we will talk about how different physiological mechanism is used in a renal replacement therapy to get specific goals, such as clearance of urea, clearance of acidemia, clearance of other electrolyte abnormalities, fluid overload, etc. Now, basically, all the work in CR or in renal replacement therapy occurs through three different physiological mechanisms and an interplay between them. The dialysis per se, renal replacement therapy per se, is used to either clear the solute or clear the fluid. So these are the main two aim of a dialysis intervention. The solutes are removed or are cleared by three different processes, as I said. Either it will be convection or diffusion or adsorption or mixture of any of those three things. Based on that, we name different modalities. The fluid is cleared by ultrafiltration. That's the only mechanism how the fluid gets out of the system. Okay. So this is the basic thing that you have to understand a renal replacement therapy. So solids are cleared by three modality: convection, diffusion, adsorption. Fluid is cleared by ultrafiltration. So whenever we aim for removing of fluid, we choose a modality that has ultrafiltration in it. Whenever we want to clear a particular sized molecule or solute, we choose a modality that can clear that particular molecule, either whether it is convection, whether it is diffusion, whether it is adsorption, or combination of that. Okay. Now, adsorption, we usually don't aim at doing it, but there are now newer modality to clear particular selective substance from the body through the adsorptive mechanism. That's slightly out of scope of this discussion. So we'll discuss this first and keep it in the bank. So adsorption influences removal of hydrophobic or lipid soluble molecules by attachment of them to a particular membrane. So the what do you call the filter in a renal replacement machine is composed of a particular type of membrane which gets bound to a particular molecule in the body that gets cleared by adsorption. More so happens with any removal of toxins such as charcoal hemoadsorption. So that's one of the function of renal replacement therapy. Particularly, it's not a replacement therapy; it is a removal therapy, but it comes in the same group of treatment. So we'll not be talking about that. We'll talking about more of a clearance of fluid and solute in a conventional way. Now, just summarizing the whole thing that I talked about, mechanisms and modality of renal replacement therapy. Either we aim at solute clearance or we aim at water clearance or fluid clearance or both. That's the main mechanism or main aim of a renal replacement therapy. And based on that, what we want more or what we want less, the predominant mechanism of renal replacement therapy is determined. Okay. Just take that C part from, this is more of a continuous modality of renal replacement or CRRT we're talking about. But irrespective of whether it is continuous or intermittent, the mechanisms are the same that we use. Okay. Whether we aim at dialysis, whether we aim at hemofiltration, or whether we aim at convection and ultrafiltration. So the different type of mechanisms which have different type of physiological principle governing them. For example, for a dialysis, you look for diffusive property of the molecule or the solute. So dialysis is diffusive property. Now, if you're thinking of only removing the fluid, hemofiltration, not the diafiltration, just the filtration. If you're thinking of this one, sorry, if you're thinking of only removing the fluid, then you talk about hemofiltration, where only fluid will come out through the membrane. Okay. But if you're talking about both dialysis and removal of fluid, then the mixed or a hybrid mechanism works, which is called as hemodiafiltration. Okay. So this is the basic physiological mechanism or physiological way where the fluid and the solutes are separated from the body. Now, if it is done continuously, it is called as a continuous renal replacement therapy. If it is done for some time, like few hours in a day, then it is an intermittent renal replacement therapy. Okay, based on your need of the patient, based on the particular disease per se, and the facility that you have, you determine what modality you want to use. Okay, suppose somebody has a very high some electrolyte abnormality, calcium, hyperkalemia. In that case, you'll probably look for more of a removal of a solute, which is the culprit solute, whether it is a calcium, whether it is potassium. In those cases, you probably predominantly aim for a diffusion to take them out as quickly as possible, because diffusion is simple. It is from a high concentration through to a low concentration area within the or through the semi-permeable membrane. So in that case, you will look for more of a diffusion property to clear the solute, the particular solute quickly. Suppose the the patient had a acute MI, and his heart is struggling, and in the ED they've given 5 liters of fluid, and he has landed up into hypoxia because of pulmonary edema. In that case, the primary aim is to remove the fluid as quickly as possible. In that case, you predominantly look for ultrafiltration to take the fluid out of the body, retaining everything else. Okay. But someone who presented to the ICU with acute and chronic renal failure because of sepsis or something, who has both fluid overload and at the same time has deranged metabolic parameters with hyperkalemia, acidosis, etc. In those cases, you have to do a modality where you clear some fluid with the ultrafiltration convection, and also you want to clear the particular solutes that are in high amount because of low kidney function, such as potassium and other azotemic substances, which has to be cleared by the dialysis or diffusion. So in that case, you look for hemodiafiltration. As I said, it says chronic because it's a CRRT modality we're talking about, but this same principle applies for any sort of dialysis or any sort of renal replacement therapy. You have to judge what you want, and based on that, you need to tailor your approach. A little bit of diffusion. So diffusion, as I said, is a solute transport mechanism along the concentration gradient through a semi-permeable membrane. So very basic fundamental thing that we have learned from our chemistry days. So you'll have a semi-permeable membrane, and blood flows on one part of that membrane, and the dialysate flows on the other part of that membrane, which are separated by the semi-permeable membrane. And there is an inherent concentration gradient between these molecules, which is higher in the blood and lower in the dialysate. And the molecule move along the concentration gradient, okay, from the higher concentration to the lower concentration. That is the diffusion. Now, very simple process, as anybody can tell, the rate of diffusion, we'll talk about that in the next slide. The rate of diffusion will depend on many things here. First of all, the concentration here and the concentration here of the solute. How bad or how good is this semi-permeable membrane? What is the blood flow there? What is the dialysate flow there? Or anything else is going on here. So there are multiple things that can alter the property of the semi-permeable membrane itself. So there are multiple things that determines this diffusion process. The mechanism is very simple, but the control is very complicated here. As I said, bit of enlarged photo of what we are talking about. So diffusion, the blood flows in the middle chamber of a filter, or a dialysis filter in layman language. The blood flows from the bottom to the top, and the dialysate flows around the blood from the top to the bottom. So that's the dialysate, the green one coming out, and that's the filtered dialysate coming out. Or after the transfer, the dialysate is coming out. So that's why it is in yellow color. So that's enlarged form of that. Blood going in the bottom to top direction. There is diffusion of substances across the semi-permeable membrane. So it can happen both ways. Wherever there is a higher concentration of the solute, it will diffuse to the other side. Okay. So very basic demonstration of diffusion here. As I said, it depends on many things. Okay. The most important thing is the difference between the concentration between the blood and the dialysate. Okay. And we talk about diffusion in terms of concentration gradient, and the rate or the efficiency of diffusion is through a index called as the solute diffusive flux, or JD. You don't have to remember all these things. The whole numerical or the formula you don't have to remember, but you need to know what determines the ability or efficiency of diffusion. For solute diffusive flux, means it is a number of molecules that passes through unit area per unit time, unit area of the filter per unit time. Okay, demonstrated as JD is equal to DAT times dC by dx, where D goes by the fixed law. Again, these are the nomenclature of the things that you are looking at, but the overall formula, if you break down, The diffusive flux is directly proportional to the surface area, no rocket science. The larger the surface area, the more diffusion will happen. The temperature, because the temperature gives more kinetic energy to the molecules and also changes the property of the filter I'm talking about a biological filter in vivo, not in vitro, and diffusive coefficient, okay? And it is inversely proportional to the radius of the molecule. The larger the molecule, the slower the diffusion will happen, and also the viscosity. Higher the viscosity, the flow will be very slow. So basically the main determining factor are surface area, temperature, diffusive coefficient, which is this one, and inversely proportional to the radius and viscosity. I'm talking about these chemistry part of things because these are silly questions in the exam. They can ask you about the mechanism that governs the CRRT. Then you need to know about a little bit about diffusion, little bit about convection, little bit about hemofiltration so that you can write something. But at the same time, you should have a clear concept about what molecule are cleared by what sort of modality. Now, mass transfer with diffusion, as we saw, is dependent on solute characteristics, type of membrane, we talked about that, rate of delivery of the solute, and concentration gradient across the membrane. So the four important factors that determines this mass transfer, how much is coming out of the blood into the dialysate. So it depends on the solute characteristics. The larger the size, the opposite charges, and the higher the protein binding will decrease the clearance of particular solute. The type of membrane, increase surface area, decrease thickness, and type. Again, polarity of the membrane also does determine the flow of solutes across that. So these are the important factor. The important factor that we can alter is the blood flow and dialysate rate. So because it is a, as you can see, it is a counter current mechanism, blood going from bottom to top and the dialysate coming from top to bottom. So you remember the Doppler effect, like if the trains are crossing each other, then the amplitudes are added. Similar principle here. If they are going in the opposite direction, the clearance is higher compared to co-current mechanism. So it's a counter current mechanism, which is similar to the kidneys or nephron. So if we increase the blood flow and the dialysate rate, then the clearance will be higher. Okay. So in the exam, Viva question, they can ask you, how do you increase the clearance of particular substance in CRRT? So increase the blood flow or increase the dialysate rate. So these are the things that you can change on your hand. You cannot change the size of the particle. You cannot change the protein binding. Usually the filter type is same, or you can use a high flux filter or a low flux filter. That's another option. But once the machine is up and running, the only thing that you can change is the blood flow rate and the dialysate rate. If you increase both of them or either of them in the counter current mechanism going on, then you can increase the clearance of a particular substance. Again, that can be a Viva questions for you. Now, diffusion utility, specific substances, as I said, diffusion, substances who are less than 20 kilodalton can be removed easily through the diffusion, which includes the urea, creatinine, interleukin 6, not all the interleukin, only interleukin 6. Some of the pesticides, ammonia, and most protein-bound drugs are amenable to diffusion. It is not able to remove larger molecule effectively, which are like complements, TNF-alpha, or other interleukins. Okay. It is reported to cause less damage to the platelets and the leukocytes because there is less across membrane transfer of these cells. Okay, so the particles do diffuse through their or based on their concentration gradient. It is not an active process. So in that case, there is less damage to the platelets and leukocytes, reported to be theoretical benefit. But not all the molecules can be removed through diffusion. Only smaller molecules can be removed. I will talk about a little bit of convection and ultrafiltration. Again, ultrafiltration is driven by the pressure gradient between the blood and the dialysate or ultrafiltrate compartment. So what happens is we create a pressure gradient between the blood compartment and the dialysate compartment so that the fluid can go from one to the other based on the pressure difference between those two components. So here there is no talking point about the size of the molecule or the concentration of the molecule. We're talking about more of the pressure difference between the chambers, the blood chamber and the dialysate chamber. So based on that, wherever the pressure is going, fluid will be cleared in that way. Okay. So as I said, dependent on the transmembrane pressure, that is the so transmembrane pressure can be dictated by the hydrostatic pressure itself or the osmotic transmembrane pressure gradient. So either it is the hydrostatic pressure or the osmotic pressure that is transferred across the membrane will determine the ultrafiltration rate. Okay, and also it is dependent on the ultrafiltration coefficient. So we'll talk about that a little bit more. Now convection. So convection is a bulk flow. That's you have to remember. What happens is with the convection, there is bulk flow together with the solvent. Some of the molecules are cleared, like they are dragged with the solvent flow. Okay, so there is a high pressure on this side of the membrane. There's a low pressure on this side of the membrane. There is a membrane there, semi-permeable, which allows the passage of the fluid. Solvent can easily go through this, which is called as a solvent drag. Along with the solvent drag, you drag some of the molecules with it. So that is the mechanism of convection. So whenever there is a movement of fluid from one high pressure to the lower pressure area, there will be drag of some of the solutes along with the fluid, which is called as the solvent drag. Okay, this is dependent on the transmembrane pressure. We talked about that, hydrostatic and osmotic transmembrane pressure gradient and the membrane characteristics. Okay, it is independent of the solute concentration gradient across the membrane. You can derive potassium from a low concentration here to a high concentration here if this solvent drag is too much, right? So if similar things with phosphate that happens with a high volume ultrafiltration, what happens is you'll get this solvent drag very significantly and you will clear a lot of electrolytes through this, even if from the lower concentration to the higher concentration, but there is a solvent drag and it will take these molecules with it. Okay, again a little bit of convection we talked about. So both convection and the ultrafiltration is dependent on the pressure difference between the blood chamber and the dialysate chamber here. So what happens is you create a positive pressure in the blood compartment, which is generated by either increasing the hydrostatic pressure in the blood compartment or increasing the blood flow rate. So if you increase the blood flow rate, there will be more pressure inside the blood compartment. Okay. Same time, you can exert a negative pressure in the dialysate chamber. This yellow chamber, you can put some suction on it, or layman language, you can say you can put some negative suction on that, so that there is a pressure gradient created between this blood chamber and the dialysate chamber, and the fluid can go from the blood into the dialysate. Along with that, there will be drag of the solutes called as the solvent drag. The solutes will be dragged, but it is called a solvent drag because it happens due to the dragging force generated by the solvent. Okay, so the only way you can increase the pressure inside the blood chamber is by either increasing the hydrostatic pressure in the blood compartment or increasing the blood flow rate. There is more blood going through this. These are the two mechanisms on the blood side that you can cause to increase the pressure here, or you can decrease the pressure here so that there is more drag is there or more pressure difference is there. So basically, diffusion depends on multiple factor, but that is more predominantly dependent on the characteristics of the solute. Convection and ultrafiltration is dependent on membrane character and the factors influencing the pressure difference. Okay. Convection is better clearance of higher molecular weight solute with a higher rate, which is interleukin 8, TNF alpha complement. So sometimes if we use convection, there may be some sort of what you call inflammatory markers get reduced with the initiation of the CRRT, which has a convection modality in it, and patient may show some degree of decrease in the inflammation rate. But again, this is a perpetuating cycle. You cannot remove the inflammatory marker saying that, oh, if you remove this amount of inflammatory marker, the patient will get better, because it is an ongoing process unless you address the primary pathology why the inflammatory markers are created in the body. This therapy is ineffective, being shown by multiple trials that um, high volume ultrafiltration along with convection doesn't help in septic patient, but can give some transient increase in improvement in the patient, because you have cleared some of the higher molecular inflammatory markers with the utility of convection. Again, going to the same slide that I said, if you look for solid clearance happens in all modality, more in the more in the diffusion modality, which is the dialysis. Based on what amount of fluid you are dragging, it can be more in the convection and ultrafiltration also. But if you want a balance between both solute removal and water removal, the mode to go is hemodiafiltration, where there is dialysis or diffusion, and also there is convection and ultrafiltration happening at the same time. So going into a nomenclature of CRRT, which my following speaker will talk about, types of CRRT. CRRT is called as different modality of treatment, or divided into different modality of treatment, such as what type of mechanism is predominant in that sort of treatment. Suppose we call it as a CVVHD, so continuous veno-venous hemodialysis. So in this case, your predominant mechanism is the diffusion, where smaller molecules are cleared, but it is a rapid diffusive clearance. You get a rapid drop in the solute from the blood. Get greater chance of disequilibrium syndrome whenever there is dialysis or diffusion as a predominant mechanism. The clearance of solute is very fast and you can have a disequilibrium syndrome. More useful for patients who have uremia, hyperkalemia, and it does need a dialysis because you need something going in the dialysis chamber. So the dialysis part, or intermittent hemodialysis, also has the same principle, more of a diffusive type of clearance. Okay. The second modality is a mixed variety of dialysis and hemofiltration, where you have both small and medium to large molecules are cleared effectively, because it has both convection and diffusion happening at the same time. More suitable for sepsis, patients with acidemia. It does also need dialysis because there is a D here where diffusion happens. And if you're talking about filtration, you need to put replacement fluid for exchange. Okay. And the third modality is CVVHF. Only here, there is no D, no dialysis, no diffusion happens. You can just pull out fluid with the hydrostatic pressure created by giving pressure on the blood chamber, or negative pressure into the dialysis chamber. So it is associated predominantly with convective clearance. It does need replacement fluid based on the aim. Like you put 200 replacement fluid and you take out 600 replacement fluid, that means you are making the patient negative 400 ml. But the mechanism is convection here. So you'll have bigger molecule clearance will happen along with some of the convective current that is generated because of the fluid removal. So that's the basic principle in a nutshell about renal replacement therapy. In summary, you have three major physiological mechanisms: diffusion, hemofiltration, and convection. Modalities are based on predominantly one or two type of mechanism that predominantly works there. Intermittent hemodialysis, or IHD, predominantly is based on a diffusive clearance. So there will be more chances of disequilibrium, rapid clearance. All this can happen with diffusion. CRRT again is a mixed balance between both hemofiltration, convection, and dialysis if you're using a dialysate. And the scuff, or the only hemofiltration that we do, is predominantly convective, where we are aiming to take out more fluid. So these principles will be used in catering your prescription for CRRT. What do you want? What type of molecule you want to remove? How rapidly you want to remove? Along with how much water you want to remove? All that will be, if you have numbers for that, then you have to titrate your diffusion, you have to titrate your hemofiltration or convection forces. Now, a brief slide on what are the type of renal replacement therapy available and the difference. I think a few of the speaker may talk about in detail about SLED. I'm just going into the difference of that. This can be a question. You have to put out a table in the exam saying that these are the difference. So usually they may ask you about uh, compare and contrast between different modality of renal replacement. So modality of renal replacement is intermittent hemodialysis, continuous renal replacement therapy, and slow low efficiency daily dialysis or SLED that you do. So these are the three different mechanisms. So this is the middle one is continuous, this is intermittent, this is a hybrid technique. The mechanism of solute removal, as I said, in the intermittent hemodialysis, predominantly diffusion, very rapid. CRRT, 24 hours ultrafiltration of small to middle molecules through diffusion, convection, or both. And in SLED, also slow and sustained low efficiency daily dialysis of small and middle molecules, mainly through the diffusion because there is a D in there. You need a dialysate here. Duration intermittent is 2 to 4 hours, so 3 to 4 hours. CRRT is continuous more than a day. SLED is usually 6 to 12 based on the hemodynamic stability or instability of the patient. Every 2 to 3 days, you have to do the intermittent hemodialysis. Dialysate rate, this is important. You need to know about this. This is the main determining factor about the utility of these modes. So the higher the blood flow rate, the more blood you remove from the patient to go into the machine, the more chances that the patient will be hypotensive with it. Okay, because you are reducing the blood volume by 500 ml per minute, so there is more chances of intradialytic hypotension again, which is again a poor prognostic marker because of the comorbidity of the patient also. So in a intermittent hemodialysis, the blood flow rate is usually more than 200 ml. So it is 300, 400, 500 ml, up to 500 ml. You can go or higher than that. But in a CRRT, we start at 150 and gradually build up to 200. So it's a low blood flow rate per minute. Okay. And in SLED around the same or slightly more. So it is in between these two modality. So blood flow rate is slightly more than the CRRT but less than the intermittent hemodialysis. So more chances of hypotension with intermittent hemodialysis. Hemodynamic instability or stability, as I said, it is poor in intermittent hemodialysis because you are taking out a lot of blood, around 400, 500 ml of blood coming out of the patient in a minute. So there's more chances of hypotension at the beginning, and also intradialytic hypotension is more. It is fairly well tolerated in case of CRRT and same as SLED. If you are worried about hypotension in SLED, then increase the duration, go up to 12 hours with the same aim. Efficiency is very high, very rapid clearance of the solutes. CRRT again low to moderate efficiency, but because the duration of the treatment is so high, like 24 hours compared to 3 to 4 liters, 3 to 4 hours, the clearance of solute and clearance of water is more in one episode of CRRT compared to one episode of intermittent hemodialysis, because you are running only 4 hours. Suppose you take out 2 liters with 4 hours, you can take about 3 liters, 4 liters in 24 hours with the CRRT. Similar with the SLED. So based on the duration, the effectiveness also increases. So not only the speed of clearance, but also the duration is also determined. So efficiency, when you say it is high, if you look at the 3 hours, yes, the efficiency is very, very high. But if you equate it to a 24-hour treatment of CRRT, probably the efficiency of CRRT higher than any other modality. Cost very high for CRRT because you have to have replacement bags and etc. And the consumable very high. So CRRT is a expensive treatment because you need anticoagulation. The next point. So usually IST doesn't need anticoagulation or a small dose of single dose of anticoagulation because of the high blood flow. The filter doesn't clot that quickly. And you are only maintaining for 4 hours, not like 24 hours. For a 24-hour therapy, you need to have some anticoagulation. That again increases the cost of treatment. In the SLED, sometimes you may need, you may not need based on the patient's background, whether you want to anticoagulate or not, but single dose of anticoagulation can suffice for SLED also. Patient's clinical conditions use, so more of an ambulatory treatment, chronic renal failure who are stable in terms of hemodynamics, CRRT, unstable patient, very sick patient, need correction of acidemia, hyperkalemia in the ICU. This is the modality of choice. And this can be transitioned into SLED later on when the patients get better hemodynamically. Complications, again, interdiabetic hypotension, as I said, similar in all of them. I don't know why this says specifically air embolism, but again, the risk of air embolism is there in any of the three. So that completes my part of the basics of renal replacement therapy. My next speaker will talk about more detail about CRRT and other modality of renal replacement, and a little more in detail, going in depth. If you guys have any other questions, I'm happy to answer. Otherwise, I'll invite my next speaker to start talking. All right, I gather there is not, I can't see any questions from the candidates. In that case, I'll stop sharing my slides.
Thank you, Sananta sir.
Thank you.
Yeah, thank you, sir. Thank you.
Niharika, are you the next presenter? Or
Yeah,
who
sir.
will-
Yeah, sir. Yeah,
Okay.
I'm going to. So guys, are you able to see my screen?
Yes, Niharika. I
Okay,
can
okay.
see.
Yeah, thank you, sir. Yeah. So good evening, all. So sir has explained beautifully about the different principles of the IHT and especially the CRRT. So I'll be discussing in detail about the CRRT. What are the components of the CRRT machine? How do you monitor it? And especially stressing on to the anticoagulation, which is very important in this CRRT, and the complications. So now coming to the outline of the topic, I'll be discussing about the introduction, the components of CRRT machine, the different modalities of CRRT, how to prescribe a dose for a patient on CRRT, what are the different complications, and the trials related to the same. So coming to the previous year questions, there were two questions which has been recently asked in your DRNB exams. One is the principles of CRRT for 5 marks, which sir already has discussed. And the second one is the anticoagulation on the CRRT. So I think most of you people, I mean, most of the hospitals, you are using the CRRT, but nearly around 25 to 30% of, you people are not using the CRRT. So this is an important question in both theory, practical, and also for your EDIC exams or any other competitive exams. So especially how to prescribe the CRRT dose is the question which they usually ask. So we will go in detail. So now what is CRRT? It is nothing but a modality of a renal replacement or a support which works round the clock, inducing less drastic and rapid fluid as well as solute shifts across the body fluid compartments in critically ill patients. This is especially used in intensive care units in patients who are hemodynamically unstable, who are on a high vasopressor support. Also, it is used in patients with raised ICP, like patients after neurosurgery or in fulminant hepatic failure. So coming to the different principles in superficial thing. So as sir told, we have two important principles. One is the diffusion, and the other one is the filtration or the convection. So in hemodialysis, diffusion is the principal mode of way of removing the fluids, and whereas in the CRRT, it could be any of the three. As sir told, CVVH, CVVHD, and CVVHDF. So if you want to remove small molecules or electrolytes which are less than 500 Daltons, then dialysis or filtration both can be used. Examples for these includes the urea, creatinine, the potassium, the hydrogen ions, and the lithium. So if you want to remove the middle molecules which are 500 to 5000 Daltons, example vancomycin, then filtration would be better than dialysis. And if you want to remove the size of the molecules between 5000 to 50,000, especially low molecular proteins like in sepsis, cytokines, complements, then filtration, that is convection, is the only way of performing this. Okay. So this is one beautiful slide which is telling about the same. So small molecules, as I told, diffusion. Middle molecules, it is convection, and larger molecules, it could be either convection or adsorption. And above 50,000, usually nothing can be removed except the albumin dialysis, which is there, the MARS. Now coming to the CRRT machine. So these are the important components of the CRRT machine. So what we have to know is, one is, what are the different pumps that are used in the CRRT? So there are totally 5 pumps which are there. One is the effluent pump, one is the pre-blood pump, the blood pump, the dialysate pump, and the replacement pump. Okay, so these are the 5 pumps. Okay, and you have something known as the bags, or the different bags which are hanging down the CRRT machine. So the one is for the effluent fluid, one is for the pre-blood, one is the dialysate fluid, one is the replacement fluid. And you have a lot of monitoring, air bubble detectors. You have a screen where you enter all the information about the patient and the settings which you require. Okay, there is some blood leak detection alarm. So it is a very complex procedure, but a very useful one. So this diagram actually gives you each part with what is the function of each part. So if you have time later, you please go through it. Okay, usually they don't ask in your theory or practical in detail about the different things, but just for your knowledge. Now the important thing is the basic components of the CRRT system. So you have the machine itself, the CRRT machine. The most commonly used one is the Prismaflex. You have the different dialyzers. You have the solutions like the dialysate solute and the replacement solute. You have the anticoagulants and the vascular access. Now we'll go with each one of it. So coming to the CRRT machine, it consists of 3 important components or units. That is a communication unit, one is the flow control unit, and the third one is the fluid control unit. So if you see here, so communication unit is the one where you enter, or the screen that is visible to us. This is the flow control unit where all your pumps are present, and the fluid control unit where all your bags are hanging. Okay. Now coming to the communication unit. So basically it consists of a touchscreen panel which contains the user manual and also input details like patient's name, age, and also you can fill the various details of the therapy. So how much of replacement fluid to be given, how much of dialysate to be given, okay, how much of calcium to be adjusted, everything you can enter in the communication or the touchscreen panel. So we can also set up the rate of the blood flow, the dialysate flow, the replacement, and the anticoagulation. This panel also gives us the pressure level at various pressure ports, as well as it alarms us in case of a clot in the dialyzer. I think you have seen normally in our hemodialysis machine also, we have a lot of alarms which buzz. So in the CRRT, you have different alarms. So if any abnormality is detected, so it gives us the alarm. Now coming to the flow control unit. So this unit contains a stator which supports the blood tubings, the syringe pumps for heparin, heparin infusion, along with some pinch valves for pressure sensing. So as I told, there are 5 pumps. Okay. So if you see 1, 2, 3, 4, 5. Okay. These are the 5 pumps. So as I told, effluent pump, pre-blood pump, this is the blood pump, replacement pump, and the dialysate pump. 2 pinch valves, as I mentioned, these are here. And here you have a syringe to be placed for your heparin anticoagulation or any other anticoagulation which we are planning. It will be placed here. Okay. So the blood flows in the CRRT machine can be adjusted from 0 ml to 450 ml per minute. So maximum is around 450. And coming to the dialysate and the replacement fluids, maximum of around 6 liters per minute can be given. And coming to the ultrafiltration, it can vary from 0 to 2 liters per hour also. Now, as I told, there is one heparin syringe pump, which is present separately in the vertical position with lower lock and infused into the positive pressure segment of the blood circuit so that it reduces the risk of air embolism in these patients. This is about the flow control unit. Now, coming to the fluid control unit, where all our bags will be hanging. So this is the lowermost part where all the fluid bags are hanged onto the side. These are usually color coded and they slide onto the bars, which have a port in their lower end through which needles can be inserted and connection to the main pump can be established. These are usually weight-based measurements. So if there is underweight or if the bag is filled, there will be an alarm which buzzes so that we need to change the bags whenever required. Now, coming to the different dialyzers which are used in the CRRT machine. So we usually use synthetic dialyzers like polysulfone or polyacryl nitrile or polycarbonate because they have a lower immunogenicity and has a better solute removal capacity. So what is the basic concept of clearance during CRRT? It is via either diffusion or convection, irrespective of the type of dialyzer which is used. Coming to the different types of dialysates and the replacement solutions that are used in CRRT. Usually these solutions are available as a premixed sterile solutions, which usually is available in a 5 liter, as a 5 liter bags. So these patients who are undergoing CRRT are already hemodynamically compromised. So which is the best dialysate that can be used is the bicarbonate dialysate because it also acts as a buffer. Lactate buffered solutions are avoided in when the patient is hemodynamically stable, hemodynamically unstable because the metabolism of the lactate to bicarbonate by the liver is impaired due to hypotension and multi-organ failure. Hence, the KDIGO guidelines tell that patients with acute kidney injury with circulatory shock or liver failure and lactic acidemia, bicarbonate buffer is the one which is to be used. So as I told, the different solutions, one is the bicarbonate based solutions where the concentration of bicarbonate is around 25 to 35 millimole per liters. And it can be used both as a dialysate as well as a replacement fluid. And most of these commercially available fluids have potassium free or potassium less because of the risk of hyperkalemia. Already these patients will be having hyperkalemia, but we need to take care that we should monitor the potassium levels properly because these patients are more prone to hypokalemia post the procedure. Therefore, we need to add some extra potassium in the bag if the patient has a low serum levels. Coming to the citrate-based solutions, these are nothing but the new generation dialysate fluids which are administered pre-filter. So when used for CRRT, the basic advantage is that additional anticoagulation is not required because one of the anticoagulation which is used for CRRT is the RCA, the regional citrate anticoagulant. So when you use these solutions, dialysate fluids, you need not to give any additional RCA in the circuit. Coming to the composition. So what is the different, composition of the fluids in the commercial fluids? One is the sodium is around 140 milliequivalents. Potassium may range from 0, 2 or 4 milliequivalents. And extra potassium is added to the bag in order to correct the hypokalemia. Coming to the phosphates. So none of the commercial fluids contain phosphorus. And hence, hypophosphatemia during CRRT is common and it can lead to respiratory muscle weakness, leading to, hence, frequent monitoring is required in these patients who are on CRRT, especially for phosphate. Calcium and magnesium, they are present in the commercial fluids in the form of a fixed combination amounts. Okay, like 1.5 to 1.75 millimole of calcium and 0.5 to 0.6 millimole of magnesium is present. Coming to glucose, so physiological glucose concentrations are present around 100 mg per dl. And there is no written protocol for glucose control separately during hemodialysis, but regular hourly monitoring during the therapy is required, which we all do during even with the intermittent hemodialysis. Coming to the temperature of the dialysate or the replacement fluid, it should be room temperature. Coming to the important component, that the anticoagulation. So anticoagulation in CRRT patient or any renal replacement patient is risky because these patients usually are hemodynamically unstable. Also, they may have concomitant thrombocytopenia or impaired coagulation due to sepsis. Okay, so we have to see properly and give the anticoagulation in these patients and monitor it properly. So what are the different ways you can give anticoagulation on CRRT? So one is the heparin infusion method. So how do you give this? So after attachment of the primed hemofilter or a dialyzer, around 5,000 units of heparin is injected into the patient via the venous bloodline. And then a constant infusion of heparin of around 500 to 1,000 units per hour is given, and monitoring is done according to the protocol, that is the APTT. I will let you know how to monitor that later. Now, this is about the infusion method. You can even give the intermittent boluses of the heparin. Okay, so how do you give this? So initial bolus of around 2,000 to 5,000 units of unfractionated heparin is given, followed by around 1,000 to 2,000 units bolus every 2 to 3 hours should be given. And here also you have to monitor the APTT levels and then give the further doses of the heparin boluses. The other one is the regional citrate anticoagulation method. This is the most reliable method of anticoagulation in CRRT. So basically, citrate infusion is started as a part of Riogicid solution. This is a solution which is available. And 1 ampule of calcium chloride is connected to a peripheral line for continuous infusion during the therapy. So basically, citrate is given pre-filter, and post-filter, when the blood is going to the patient, you're going to connect a calcium chloride solution. Why is this? I will let you know later. The rates of citrate and calcium infusion should be adjusted accordingly. And the last method is the heparin-free method, where you give a saline solution flushes of around 100 to 200 ml every 30 minutes, which basically helps to wash up the fibrin strands from the membrane. However, the membrane efficacy may be compromised or the filter half-life may be reduced in these cases. So this is the 4 methods of giving anticoagulation. I have explained in detail about the regional citrate anticoagulation in my further slides. Now, this is the slide which is showing about the different monitoring which I was telling. So if you are using the heparin infusion protocol, okay, so you have to maintain the arterial APTT of around 40 to 45 and venous APTT around more than 65. And if there is any abnormality, like if the arterial APTT is more than 45 seconds, you have to decrease the infusion rate by 100 international units per hour. And if it is less than 40, you have to increase by 200 international units per hour. Similarly, if the venous APTT is less than 65, you need to increase the heparin by 100 units per hour, but only if arterial APTT is less than 45. Similarly, you have to monitor the regional citrate anticoagulation depending upon the ionic calcium. Okay, so this is a bit complicated. You need not to know it, but some monitoring, 4 important monitorings are there, which I'm going to discuss later. Now coming to the vascular access. Since CRRT is a continuous process, your vascular access should be, basically it should be perfect enough. Okay, the insertion technique or where are you inserting, because once it is clotted, the entire system has to be removed. Already it is a costly procedure. So we need to have a proper vascular access. So do not use AV fistula techniques for CRRT. Why? Because the access flow is a problem due to profound shock. Second, prolonged therapy can cause needle dislodgement and extravasation of the blood. So if any patient has a AV access for his previous CKD, don't use it. So which is the preferred temporary access? It is the right internal jugular vein, because it allows a more direct route to the superior vena cava as compared to the left jugular vein. So length of the catheters are also important. If you are using the right side, it should be at least 13.5. And if it is a left internal jugular, it should be at least 16 to 20 centimeter. And it may be left for a period of around 3 weeks, since the risk for bacteremia may increase after 3 weeks. Femoral vein should be considered as a second choice for CRRT. And if it is subclavian access, better it is discouraged because it leads to the stenosis of the vessel. So this is the table which is telling about the different sizes of the catheters. Okay, how much right IJB, left IJB. Okay, so where should be the tip located, everything. Next comes the modalities. As Sir told, 3 important modalities of CRRT. One is CBBH, CBBHD, and CBBHDF. Okay, So you can also do scuff in the through the CRRT machine. Also, you can do a therapeutic plasma exchange too. So we will be discussing in detail about the first three. Okay. So coming to the first one, the CBV-HD. So hemodialysis. So in hemodialysis, what is a principle which is used is the diffusion. Okay, so the dominant method for solute, basically it clears the solute. If it is solvent clearance, then it is convection. Okay, so the dominant method for solute clearance is the diffusion. So that is used in CBV-HD. So in order to enable fluid removal, some form of convection is also used in CBV-HD. So what are the characteristics of this? So basically it runs with low blood flows around 80 to 150 ml per minute. So when such blood flows are used here, so you need to use a anticoagulation, otherwise it may lead to filter clot. Okay, so the ideal one is to use the regional citrate anticoagulation. The clearance is independent of the blood flow. Okay, and how to give a dose for CBV-HD? So it is nothing but a sum of dialysate and the ultrafiltrate flows. Okay. Now this is the diagram. So you're going to remove the blood, okay, from the patient. So you're going to give the anticoagulation here. So the blood enters the hemofilter through which the dialysate enters here and the effluent comes out, and then the blood is sent to the patient. Okay. This is about the CBV-HD, or also the same applies for the intermittent hemodialysis. Now coming to the CBV-H, that is nothing but the hemofiltration. Okay, so the dominant method here is the convection or filtration. So basically this involves the removal of the solvent, okay, and some amount of solute also. So what are the characteristics of the CBV-H? So this requires relatively high blood flows compared to the CBV-HD. Okay, so here you can use a blood flows of around 200 to 300 ml per minute to maintain sufficient adequacy and to prevent coagulation. So when such high blood flows are required, your vascular access should be optimum. Okay, there is excellent clearance of the middle molecule, middle molecular weight molecules. As I told, the middle molecules are better removed by convection. Okay, the filtered fluid has to be replaced by a substitution solution, or also known as a replacement fluid. This replacement fluid can be given pre-filter or it can be given post-filter. Okay, so what is the dose of CBV-H? So it is nothing but a sum of replacement fluid, that is pre plus post dilution replacement fluid, and the ultrafiltration rates. So just keep in mind, in hemodialysis, CBV-HD, the dose is given by the dialysate flow plus the ultrafiltration rate. In CBV-H, okay, where we use only replacement fluid and not the dialysate. Okay, so here the dose will be replacement fluid plus the ultrafiltration. Now, if you come, okay, I will discuss. So this is the same. So there is no dialysate here as seen in CBV-HD. There will be only replacement fluid or the substitution fluid. So it could be either pre-filter, also known as pre-dilution, or it could be post-filter or post-dilution. Okay, the other things are the same. So blood entering through this, anticoagulation, filter, effluent coming, and blood going to the patient. That is the same. Only the dialysate is not there. Sorry, the dialysate is not there, but additionally you have something, the replacement fluid, which can be given pre-filter or post-filter. Now, as I told, this replacement fluid can be given pre-filter and post-filters. Now, if you give pre-filter, what happens? Now, if you see, so the blood is, to access, the blood is going through the blood pump. This is the filter. Okay. So pre-filter, there is a replacement fluid. So if you give the fluid, replacement fluid pre-filter, you are going to decrease the risk of clotting because you are decreasing the hemo concentration in the filter. Okay. Okay. So you can achieve higher UF capabilities, but the disadvantage is that you will be decreasing the hematocrit in the filter. So patient also receives less hematocrit. So that is a disadvantage of pre-dilution. Now coming to the post-dilution or post-filter replacement fluid. If you see here, so the replacement fluid post-filter, okay. So if you put it post filter, what happens? So you'll be achieving lower replacement rates, but you will be achieving high blood flow rates. But you require additionally high anticoagulation, because here the filter will not be diluted. Okay, so the viscosity or the hemo concentration in the filter will be more. Hence, you require a higher anticoagulation for this post dilution replacement fluid. But the thing is, it has more efficient clearance, more than 15% increased clearance compared to pre-filter dilution. Okay, so that is the advantage of post dilution. So we know that both of them have an advantage and disadvantage. So experts suggest splitting this replacement fluid as 1/3 pre-dilution and 2/3 post-dilution. So when you split it, the advantage of pre-dilution is that the clotting, the hemo concentration in the filter will be less. So the clotting of the filter will be reduced. But if you put post-dilution, then your efficiency increases. So basically it solves the problem. Okay, so 1/3 pre-dilution and 2/3 post-dilution. Okay. Now coming to the last one, the CVV HDF. Okay, so basically it combines both the hemodialysis, that is the diffusion, as well as the hemofiltration, that is the convection. So here you have both. So CVV HD has dialysate, CVVH has replacement fluid. So when you combine both, so this is the figure that is there. Okay. Now this is the different modalities of the CRRT. I think I'm clear till now. Any doubts? Can I continue? Okay, perfect. Now setting the CRRT machine. Basically, how to prescribe dose for a patient on CRRT. Okay, so prescribe the machine settings which determine the safety and efficacy of RRT treatment. So what is the patient's name, age, okay, how much of replacement fluid, what and all, we have to first set it. So you have to see the following parameters. One is, what is the dose of exchange, the ratio of pre and post dilution, what should be the blood flow, what is the net ultrafiltration rate, and what is the anticoagulation which we use here. Okay. Now coming to the treatment dose. Okay. So the treatment dose in CRRT is known as effluent volume or effluent flow. Okay. So this is given as ml per kg per hour. Okay. So the dose is known as effluent flow and it is given in ml per kg per hour. So the KDIGO guidelines recommend the effluent flow to be 20 to 25 ml per kg per hour. Okay. So just keep this in mind. So increasing the dose beyond this 20 to 25 ml per kg per hour is not beneficial and may actually result in the losses of phosphate, antibiotics, and also the heat. Okay. So there are a lot of trials which have been done with this. So the two important trials are the ATN study and the renal study. Okay, both of which told about the dose of the effluent volume in CRRT. Okay, so they have demonstrated that there is no benefit in survival or recovery of renal function with higher doses of RRT. Okay, there are also a lot of subsequent meta-analysis which has been done, and that also concluded that higher intensity RRT did not reduce mortality rates or improve renal recovery in patients with AKI. Okay. So this is about the effluent flow. Okay, that is very important. Okay, second, about the blood flow and the filtration fraction. This is also one important concept to reduce the hemo concentration. So what is the filtration fraction? It is nothing but the ratio between, we know what is effluent flow, right? Effluent flow by the blood flow rate. So that is nothing but the filtration fraction. And this represents the degree of hemo concentration along the filter. Okay. This is very important in convection techniques. That is the CVVH or CVVHDF. Okay. So what happens in convection techniques? There is high plasma water removal, right? It is basically the solvent drag. Okay. So which leads to significant blood concentration along the filter. That is nothing but the hemo concentration. which leads to increased blood viscosity, leading to filter obstruction and early filter loss. Okay. Hence, this filtration fraction is very important. So all the modern devices, they display this filtration fraction value on the machine screen, and it has to be kept below 25%. And if you are using efficient citrate anticoagulation, it can be an increase of 5, that is 30 can be accepted. Okay, so this filtration fraction is important. So basically what I told, it is nothing but the effluent flow divided by the blood flow. Okay. So how to reduce the filtration fraction? Most important factor is you have to increase the blood flow. It is in the denominator, so you need to increase the blood flow. Okay, how do you increase the blood flow? One is you have to, select a proper catheter size, and the insertion should be adequate. Okay. Second is you have to increase the proportion of substitution fluid being infused pre-dilution. As I told, if you increase, if you give replacement fluid pre-dilution, the chances of filter clotting are less. So this is one of the way you can reduce the filtration fraction. And the third one is basically effluent flow. So it is in the numerator. So we need to decrease the effluent flow, but at the consequence of inadequate or ineffective removal of the solutes or solvents. So this is the last way of reducing the filtration fraction. Two important, one is the increasing the blood flow. Second is pre-dilution replacement fluid. Okay. So this I've already discussed, pre and post dilution. What is pre-dilution? What is post-dilution? Okay. And how it has to be given 1/3, 2/3 ratio. Okay. So increasing the proportion of pre-dilution will reduce the hemo concentration, but will at the same time decrease the efficiency of the dose because the concentration of the solutes entering the filter is decreased. Okay. So efficiency will be reduced. So better to divide it into pre-filter and post-filter. Now next coming, how to keep the ultrafiltration rate in the CRRT. Okay. So this is nothing but the net ultrafiltration rate. It is known as UF net ultrafiltration. So it corresponds to the volume of ultrafiltrate removed during RRT and is usually expressed in ml per hour. Okay. So if you remove insufficient ultrafiltrate, it may lead to fluid overload and acute respiratory failure. But if you remove excessive ultrafiltrate, it may lead to hemodynamic instability due to decreased cardiac preload. So proper ultrafiltration should be kept. So a practical approach is to set the ultrafiltration at RRT initiation based on the fluid overload status of the patient. What is the hemodynamic status? Okay, like whether the patient has high lactate levels, high vasopressor dose, pre-existing preload dependence, and low cardiac output. Everything has to be seen. In general, how to set this ultrafiltration rate? So if we won't do the first one. In an anuric patient, if you want to have a positive fluid balance, no one will expect. You just keep the ultrafiltration as 0. Okay. But in a ventilated patient, you have to maintain both the fluid balance, a net fluid equal balance. Okay. You can keep a ultrafiltration between 50 to 100 ml per hour. Okay. But if you want to have a negative fluid balance, you need to adjust the ultrafiltration rate to more than 100 ml per hour. Suppose if the patient presents with acute pulmonary edema and leading to acute respiratory failure, then he might require more than 200 ml per hour of ultrafiltration rates. Okay. But this might lead to hemodynamic compromise in a CRRT patient who is already, basically we have initiated it because of hemodynamic instability. So the best one is to keep between 50 to 100 or 100 to 150 maximum. This is the ultrafiltration rate that we usually keep it in a CRRT patient. Okay. Now I am going to prescribe, I'll explain this, how to prescribe a CRRT dose for a patient weighing 60 kg. Okay. Please go through this properly because you have to give me the dose for CBBHDF. Okay. So now coming to CBBH. So what is CBBH is? Hemofiltration. So can anyone tell me in hemofiltration, what do we, what is the effluent, dose which we use? Anyone please? CBBH?
25.
Yeah, effluent flow rate will be 20 to 25.
20 to
Okay.
25 ml per
Okay,
kg.
but the thing is, one thing you have to remember is, most of the studies, especially this renal and ATN, when they have done the studies, they saw that they have reached this dose in about 85% of patients. Okay, but in 15% of patients would not be able to achieve this dose. Why is it? Because some treatment interruptions are there. Patient might suddenly become hemodynamically unstable. Okay, or you want to take the patient to the CT or MRI. So what they have done is, so they told 20 to 25 ml per kg per hour, right? So they've given us +5. So start the prescription at 25 to 30 ml per kg per hour, so that this 5 ml per kg per hour is the additional thing we are providing, because to compensate for this 15% loss which is there. Understood?
Yes, ma'am. Yes,
Okay.
ma'am.
So in CVVH, so the effluent flow is equal to what? So how do you adjust? Example, in CVVH, I told you're going to give replacement fluid, plus you have to remove the ultrafiltration, right?
Yes, ma'am.
Whereas in CVVHD, hemodialysis, you use a dialysate.
Dialyze it.
There is no replacement fluid, right?
No replacement.
Yes.
Mm.
Now it's the same thing. So as I told, dose is 25 to 30 ml per kg per hour, right? So it
Yes,
comes
ma'am.
up to 1.5 to 1.8 liters per hour, okay, for a 60 kg person. Okay. Now this you have to divide. So as I told, effluent flow is nothing but in CVVH, the replacement fluid plus the ultrafiltration rate or ultrafiltration net. Okay. Now, as I told, first you calculate this ultrafiltration. How much of ultrafiltration this patient requires? As I told, keep it around 50 to 100 or 100 to 150, depending upon the patient's situation. At present, we will take the UF as 100 ml per hour. Okay. So just if you take it as 1.5 liters, okay, as 25, 1.5, you minus 100 in 1.5. So it will be 1400 ml, right? Remaining.
Yes, ma'am.
So that 1400 ml should be kept as a replacement fluid. Okay. Now I told replacement fluid should be given pre-filter as well as post-filter. So pre-filter is 1/3, post-filter is 2/3. So again calculate. 1/3 of the pre-filter of 1400 will be
420 and
420,
980.
and post-dilution it will be 980. So this
840.
completes the 1400 plus 100 ml of ultrafiltrate. Right?
Yes.
Yeah. And as I told, this is how you give the effluent flow in case of CVVH. And additionally, the blood flow. As I told, blood flow in CVVH is slightly higher than the CVVHD. So it is around 200 to 300 ml per minute. So start with 200 ml per minute. And anticoagulation, which we use, is the renal citrate anticoagulation. Okay. So this is how you give a prescription for CVVH. What is the dose? What is the effluent flow? How do you divide this effluent flow into ultrafiltrate and replacement fluid? What should be the blood flow? What should be the anticoagulation? This you understood?
Ma'am, we made the replacement fluid 1400 because we set to UFS 100.
Yes, yes. Suppose if
Okay,
you're setting
okay.
the UFS 200, you want to remove.
Then
So
it's
the remaining will be
1300.
1300, which was divided into pre-filter and post-filter.
Yes, ma'am. Yes, ma'am. Okay.
Understood, right?
Yes,
Oh,
ma'am.
this is how you give a prescription here. So this is very important, because I think, I mean, most of the, I don't know whether in practicals also they might ask you this, and especially in all the competitive exams also, they are asking about this, especially in the EDIC if you're planning to give. Okay. Now next is the CVVHD. So in CVVHD, we don't use the replacement fluid. What we use is only the dialysate fluid. Okay, same. So dose is the same, 25 to 30 ml per kg. So it comes to around 1.5 to 1.8 liter. So here the effluent flow is the dialysate flow plus net ultrafiltration rate. Okay. So the net ultrafiltration rate, here also I have taken it as 100 ml. So the remaining will be 1400, which can be used as a dialysate flow, or there is specific actually, which is mentioned in the CRRT, that the dialysate flow rates can be kept up to 15 to 25 ml per minute. Maximum is 25. So when you keep it as 25 ml per minute also, this will come as 1500 ml. So it is nearly same. The calculation will be nearly the same. Okay. So the blood flow compared to CVVH, here the blood flows are less. So keep it as 80 to 150 ml per minute. Anticoagulation is same as regional citrate anticoagulation. Understood?
Yes, ma'am. Yes, ma'am.
Yes, no? Okay.
Yes, ma'am.
So, okay, I will just wait for 5 minutes. Can anyone give me the prescription for CVVHDF?
So that should include the effluent flow, should include replacement fluid, dialysate flow, and UF, ma'am.
Perfect, perfect, right.
So dose will be 25 to 30, and
Correct.
again same 1.5 to 1.8. So
Hmm.
U of 100 ml per hour we subtract, so that will come. So replacement and dialysate have to be divided between 1,400,
Yes.
and replacement should after that I don't know, ma'am.
Okay, so at this point, actually, the dialysate flow will help you actually. Okay, here, which I told 15 to 25 ml per minute, this will actually help. So you take to the minimum point, 15 ml per 15 ml per this is sorry, this I given as minute, right?
Yes, ma'am.
15 ml per minute. Okay, so
Hmm.
you have to convert it into R. Okay,
Okay.
so 15 into 60 will be around
900,
900. So the remaining will be around
500,
so divide that 500 into
pre and post.
yeah, pre and post. Okay,
Okay,
but
okay.
you
So we have to give more importance to dialysate flow.
dialysate flow. Okay, but suppose it depends on the patient's condition also. So if you want to remove more of the solvent,
Okay.
okay, then the replacement fluid has to be increased, right? Because if you're removing more of the solvents, then the replacement fluid is the important thing that you have to adjust.
Yes. Okay.
Okay, so basically you have to see and do. Usually CVVH they will ask everywhere. So just
Okay.
go through the CVVH, okay?
Sure.
Okay. So these 3 important points are important. So the recommended delivered CRRT dose for AKI patient is 20 to 25 ml per kg. To compensate for the gap between the prescribed and the delivered dose, an addition of 5 ml per kg per hour should be prescribed, right? Now keep the filtration fraction, as I told, below 25% with heparin and 30% with citrate anticoagulation. And net ultrafiltration is to be set based on the treatment goals, whether the patient is fluid overload, hemodynamic status, everything has to be seen. Actually, prescribing the dose for CVV-HDF is little bit difficult compared to the other two. Okay, because there you have to see all the conditions, whether solvent is important, what is the hemodynamic status of the patient, whether we can remove the ultrafiltration. So everything should be considered. So it is a bit difficult. So I don't think they'll be asking you CVV-HDF in the exam, but at least you should be thorough with the other two prescriptions. Okay. Now, the important thing which has been asked for your exam is the anticoagulation. So I've already discussed in brief about what are the different modalities of anticoagulation on CRRT. So little bit in detail because it's a 5-mark question. So as we know, no matter which modality is applied, blood circulation through a non-biological tubes and materials, that is known as the extracorporeal circuit, will lead to activation of platelets and coagulation pathways, leading to the formation of microthrombi. So these microthrombi, they tend to deposit within the filter and throughout the circuit, leading to impaired blood flow and the circuit failure. Hence, to maximize the circuit lifespan, effective anticoagulation is required. So the basic aim of this anticoagulation is to maintain the patency of the extracorporeal circuit while minimizing the patient's complications, because a lot of side effects are present with all this anticoagulation. Now, there are 2 verdicts. This is just for your knowledge. So what is clotting and what is clogging in CRRT? Okay, what is clotting is the occurrence of a thrombus somewhere along the RRT circuit, including the lumen of the fibers. Okay, when the clotting of the circuit happens, or the the filter happens, what happens is there will be an elevated pre-filter and venous pressures. So you will get the alarms, elevated pre-filter and venous pressures. So then you should think that there is some clotting happening in the circuit. But what is clogging? Clogging is nothing but it is the saturation of the RRT membrane pores, which and represents a decrease in the filter exchange capacity. So when this happens, the transmembrane pressure alarm will increase. So basically this is clogging, lot of, basically you need to change the filter in this situation when the clogging happens, because the exchange capacity is already reduced badly. Okay, so these are just 2 wordings which just you keep in mind. Now, so there are systemic anticoagulants and the regional anticoagulation. So first we'll discuss about the systemic anticoagulation. So it represents a default anticoagulation strategy for RRT in most units, especially the intermittent hemodialysis or the SLED, which we do. So it can be done with either with an infusion of unfractionated heparin, or it can be done with a bolus doses of heparin, which I've already discussed. Although low molecular weight heparin can be used, their kinetics during AK and RRT are unpredictable. So systemic anticoagulation prescription, it needs to balance the benefits with the risks of systemic bleeding. So to ensure adequacy and minimize the toxicity, this anticoagulation, the heparin, has to be monitored by the APTT, which is a good predictor of the risk for filter coagulation as well as the patient hemorrhage. So what are the common targets? So the APTT levels should be 1.5 to 2 times the baseline, or you can also monitor the anti-10A levels, and which has to be kept between 0.3 and 0.6 units per ml. So lower targets are useful in patients with increased risk of bleeding. So to reach these targets, I told how much of bolus should be given and what is the continuous infusion should be given and how it should be monitored already. Okay, so the heparin might be administered directly in the circuit, or it can be given either systematically. But what are the side effects of this unfractionated heparin? One is there is increased risk of systemic bleeding. It could be intracerebral, hematomas, surgical wounds, anything. And the second important one is the heparin-induced thrombocytopenia. And in some cases, you need to give even subtherapeutic anticoagulation, which are those conditions, as I told, if already the patient has a risk of bleeding complications, like if the patient is having underlying thrombocytopenia, which is very common in sepsis, if the patient has CLD, hepatic dysfunction, post-surgical patients, TBI patients, malignant hypertension patients, all these patients have increased risk of bleeding, where we need to give a subtherapeutic anticoagulation dose of heparin. Second is if there is a presence of abnormal coagulation tests like prolonged APTT or increased INR that often do not reflect the bleeding risk. And the third is there are frequent interruptions associated with the procedures where you need to give, suppose if you're planning for a central line, then you have to give a subtherapeutic anticoagulation. So a lot of problems with by giving this heparin, right? So altogether, anticoagulation with heparin is associated with relatively shorter filter lifespan in real life. Therefore, alternative anticoagulation strategies have been proposed. So in that, the important one is the regional anticoagulation. So what is this? To minimize complications which are associated with systemic anticoagulation, strategies have been developed to restrict the anticoagulation only to the extracorporeal circuit. So this is not going into the patient's blood. It is only in the extracorporeal circuit. So that is known as regional anticoagulation. So restricted to the hemodialysis mission, the particular region. Okay. So this regional anticoagulation involves the administration of anticoagulant at the beginning of the circuit, and you have to give its reversal at the end. Okay. So example, if it is a regional citrate anticoagulation, so pre-filter, you're going to give the citrate, and post-filter, when the blood is reaching to the patient, you're going to give the calcium, which is nothing but the reversal of the citrate. Okay, so regional citrate anticoagulation. There are several RCTs and meta-analysis which have demonstrated that compared to heparin, the regional citrate anticoagulation was associated with increased filter lifespan as well as decreased need for blood transfusions. So now the KDIGO guidelines from 2012 only, they recommended RCA as the first line anticoagulation for CRRT. So now, how does this the citrate anticoagulation acts? So basically, citrate anticoagulation has a higher affinity to calcium. Okay, basically it chelates the calcium. So when you give the citrate, okay, this is basically in the CRRT system. Okay, it's not in patient's blood. Okay, so CRRT anticoagulation. Okay, so what I told, citrate has greater affinity to the calcium. So when the patient's blood goes into the filter or into the circuit, this citrate combines to the calcium, okay, and leads to the formation of something known as citrate calcium complexes. So when this is formed, okay, the concentration of ionic calcium in the circuit is decreased, okay. And as we all know, calcium is actually a cofactor for the majority of enzymes in the coagulation cascade. So if you see, this is the intrinsic pathway, this is the extrinsic pathway. So you have conversion of this factor 9 to factor 9A. you have the calcium. Here, calcium, calcium. So everywhere it is calcium dependent. Okay. So when the calcium concentrations falls, so what happens? There is no generation of thrombin. So this is a way this citrate acts as an anticoagulant. Okay. So since calcium is a mandatory cofactor of majority of enzymes in the coagulation cascade, a plasma calcium level, you should maintain it below 0.35 millimoles per liter to have an effective anticoagulation by the citrate. Okay, I'll come how to monitor later. So as I told, a calcium chloride solution must be administered to compensate for the calcium losses in the effluent. So what happens if you see this diagram? So patient's blood going into the circuit, you are giving the anticoagulation, the citrate solution here. Okay, so then it forms a citrate calcium complex, which around 30 to 60%, this complex will come into the effluent fluid. So you're actually losing the calcium here. Okay, so the remaining complex around 40 to 70% goes into the patient's blood, but you're losing a calcium of here around 30 to 60%, right? So you have to near the patient end, you have to give a calcium chloride solution continuously to prevent hypocalcemia, which is one of the complications of citrate, anticoagulation of citrate toxicity. Okay. So a calcium chloride solution must be administered to compensate for calcium losses in the effluent. The residual complex, it returns to the body and are metabolized at the cellular level as in the Krebs cycle. So this is how the principle, how it works as anticoagulation. So just something about the citrate. Under normal conditions, the citrate has an approximately a half-life of around 5 minutes. And the process generates some energy, around 593 calories per millimole of citrate. And it also releases sodium as well as calcium ions during this anticoagulation. During the anticoagulation time, this is the one which happens. So in terms of acid-base balance, okay, so what does the citrate do? Okay, this has an alkalotic effect. So it leads to metabolic alkalosis. Also, in some cases where there is accumulation of citrate, it can also lead to metabolic acidosis. I'm going to discuss it later. Okay. Now, you know the citrate, what is the mechanism? Okay. Now, what are the caveats of using the regional citrate anticoagulants? As we know, it is safe and associated with the fewer complications than the systemic heparin anticoagulation. However, if inadequately managed, it might be associated with electrolyte as well as acid-base complications. So, two important complications of this citrate. One is the citrate overload. One is the citrate accumulation, also known as citrate intoxication. So, what is citrate overload? What happens here? The net citrate administration basically exceeds the body's alkalotic requirements. Okay, so this leads to metabolic alkalosis. Okay, so this is a milder form. But coming to the most severe form, that is the citrate accumulation, also referred to as citrate intoxication. Here what happens is, this is a more severe situation. Here the body is unable to metabolize all the complexes. It could be secondary to shock, mitochondrial blockage, or severe liver disease. It leads to severe hypocalcemia and metabolic acidosis. So milder form, it leads to metabolic alkalosis. Very severe form, it leads to metabolic acidosis. Okay. So citrate accumulation must be suspected in the presence of an elevated total bi-ionized calcium ratio. So this comes in monitoring. If severe citrate accumulation requires therapy interruption. Okay. And what is the other thing? Hypomagnesemia also. Citrate to some extent chelates even the magnesium ions. So we have to daily monitor or every 6 hourly monitor the magnesium levels when the patient is on CRRT. So this is the complications of citrate anticoagulation. So it may lead to citrate toxicity. It may lead to citrate metabolic effects like added calories, lactic acidosis. And the most important thing, it may lead to, as I told, it generates sodium during the process. So it may lead to hypernatremia, hypocalcemia because it chelates the calcium, metabolic acidosis in case of severe, that is citrate accumulation, citrate toxicity, you will have metabolic alkalosis. And since it chelates even some of the magnesium, it may lead to hypomagnesemia. So if you just draw this as a complications for citrate, then you will get good marks in your exam. Now the important, very, very important, see when you see this monitoring, then you see how difficult it is to manage a patient on a CRRT. Okay, so how to monitor the patient on CRRT? 4 important things has to be monitored. One is you have to monitor the post filter or the circuit ionized calcium. Okay, so post filter. Why do you do that? To monitor how efficient is the anticoagulation. So you're giving it pre-filter, the citrate. So immediate post filter, or you can measure the filter calcium also. Okay, the blood which is flowing into the circuit. Okay, so according to the protocol, a post filter calcium between 0.2 and 0.35 millimole per liter should be achieved. Okay, so if this is achieved, then you feel that the anticoagulation is efficient. Okay, so citrate to blood flow ratio can be set on the CRRT device until this target value is reached. Now, second is the systemic ionized calcium. Why do you want to measure this? Because you have to see how much of calcium replacement you require for the patient. Okay, because as I told, hypocalcemia, and it is also one of the reversal for the citrate. So you have to measure the systemic ionized calcium, that is nothing but the patient's calcium, ionized calcium. So normally it should be between 1.1 to 1.2 millimoles per liter. Okay. The third one you monitor is the total by ionized calcium. This actually have told it before. So why do you do this? To see whether the patient has citrate accumulation. Okay. So what should be the ratio? It should be more than 2.5. Okay. If it is more than 2.5, then it highly is indicative of citrate accumulation. Okay. And then you have to monitor the magnesium levels. So there is so much to monitor the calcium everywhere. So post filter, systemic, total by ionized calcium, and the magnesium levels. Okay. So this is about the regional citrate anticoagulation. Coming to the other regional anticoagulations which can be used, this is very rarely used. One is heparin pre-filter and its reversal protamine post-filter can be used, or prostacyclin in some cases has also been used in CRRT. Now coming to the non-pharmacological approaches to anticoagulation. Okay, it's not been well studied in CRRT patients. However, when all forms of anticoagulations are contraindicated, then you have to optimize the filter's lifespan by some non-pharmacological approaches. First one is by minimizing the hemoconcentration. So as I told, hemoconcentration, how to minimize? You have to keep the filtration fraction less than 25%. Okay, and the second one is by giving a pre-filter replacement fluid. And the third one is by keeping the higher blood flow rates. Okay, this is one of the ways. The remaining are, you have to ensure that the catheter performance is good. You have inserted an adequate sized catheter in an appropriate place. Then reduction of blood air contact in the bubble trap. Then there are some specialized filters which are available, which have some large membrane surface area, or it might be coated with special, special fibers or special material. Okay, like AN69 membranes. So you can use those. And saline flushes, we use it even in intermittent hemodialysis. There are some built-in device strategies which actually tell that if there is a low blood flow, it will actually give an alarm so that you will identify it before. And prompt reaction to the machine alarms that are associated with interruptions of blood flow, which we usually don't do even in intermittent hemodialysis. So we need to, prompt reaction has to be present for any alarms of the dialysis machines. So now coming to the complications of the CRRT. So one is, we know the vascular access related complications. Second, I told electrolyte and acid balance disorders. Third is drug clearance. So this is one of the topic, the drug clearance in CRRT is a very big topic. So if time permits, we'll discuss it later. So a lot of drugs, how to give it, whether to give full dose, what and all, we will discuss it later. Then the third one is nutritional and physical deconditioning. Volume-related cardiac stunning. That is, if you remove a lot of ultrafiltrate, then it leads to cardiac stunning because of hypotension, hypothermia, and hematological complications. So these are the complications of CRRT. This is just a table which is giving in detail about these complications. So if you have time, just go through it. So in vascular access, bleeding complications, insertion related like thrombosis, hematoma, pneumothorax, air embolism, arrhythmias, anything can occur. Then infectious complications can occur at catheter exit site, sepsis. Then how to prevent it, how to manage, everything has been given. Now, extracorporeal circuit related factors like air embolism, reduced filter life, reduced dialysis dose, hypothermia. Coming to hematological, as I told, anticoagulation related like systemic bleeding can happen, and citrate related toxicity, heparin induced toxicity like HIT, okay, hemolysis. These are all hematological factors. Then as I told, a lot of electrolyte and acid imbalances. Yes, some nutritional losses can happen, and physical deconditioning can also happen. Now, I think this slide actually sir has shown, Sananta sir has already shown you. So I'm not going to go in detail. So basically you should know what is the mechanisms in each of the method of RRT. What is the solute shift mechanism? Blood flows, as sir told, more than 200 in IHD, less than 200 in CRRT. In between will be the SLED. Coming to the durations also, you know, CRRT is for 24 days. 24 hours per day, sorry. Now, what are the advantages or special uses? So for IHD, the advantages, you can remove the rapid, fluids can be removed rapidly. The solute clearance is rapid. And in cases of severe hyperkalemia, as in CKD patients, the best one is to do a IHD. But if the patient is hemodynamically unstable, if you want to have a better fluid control, okay, not lot of hemodynamic variations, and if you have high nutritional support, and if you want to remove especially the middle molecules where convection is an important principle, so CRRT can be used. Now, the last two slides about are the different trials of CRRT or the RRT. Coming to the dose of CRRT, as I told, two important trials. You have to remember this. One is the ATN trial and the renal trial, where I've already discussed. So basically, this ATN trial has given the dose comparison for all the three. The CVV HDF for the SLED and also for IHD. Okay. So what they have done, there are two things. One is they have compared of CV, only I will discuss about the CVV, CRRT. So they have compared between 35 ml to 20 ml per kg per hour. Okay. And they have seen the 60-day mortality. There was no much difference. So at day 28 also, no difference in complete or partial recovery of the kidney function. But there are a lot of hemodynamic instability. There is a lot of loss of electrolytes, nutrients when you give a high dose of CRRT. So better to give a 20 ml per kg per hour is the conclusion that they have made with ATN. Coming to the renal trial here, this is only of the CRRT. So here they have given post dilution 40 ml versus 25 ml per kg per hour. So 90-day mortality, no significance. So there is also no difference in the recovery of kidney function or dependence on RRT. Okay, so both of them supported 20 to 25 ml per kg per hour. Now, this is trials on the timing of RRT. There is no specificity. It is only for CRRT or IHD or SLED. So these 5 trials are very important. It can be applied to all the 3. So you have the Ilian trial, Akiki, Ideal ICU, Start AK, and the recent one is the Akiki True. Okay. So initially they told that early dialysis is has a better outcome. So, but as the years are proceeding, like recent years, so they are telling better to do a delayed start the dialysis in the later stages than the early one. So here basically, so they have if you see, so early initiation is within 8 hours, whereas delayed initiation is within 12 hours, or there is no initiation in Ilian. Okay, and they showed that there is a shorter RRT duration and hospital stay in the early group. Okay, whereas mortality, there is a lot of mortality difference also. If you see at the 90-day, if you have performed the RRT in the earlier periods, the mortality is actually less compared to when you have done it in the delayed period. But as you see later, early versus late, there is no statistical significance at all. Okay. So you have to go through these, I mean, all the trials in detail, at least the Akiki 2 trial, because it is a recent one. So please go through them properly. This is an easy way, just I have kept it. Okay, thank you. So any doubts, please ask. So any questions? I think some 2 questions are there. Patients, ma'am, can you please explain regarding the solute and solvent part? So Amrita, what doubt you had? I didn't understand. Amrita, are you here?
Yes, ma'am, I'm here. Ma'am,
Yeah, Amrita. What is this, ma'am? Can you explain regarding the solute and solvent part?
Yes, ma'am. Somewhere you mentioned that you have to remove the solute, and somewhere you mentioned that you have to remove the solvent. I just got confused in between that.
No. Basically, see, solutes will be the best way to remove the solutes is the hemodialysis. Okay, I think sir has explained it in detail. What is solute? How to remove solute? What is solvent drag? If you want to remove a lot of water, that is a solvent, then the convection is a better method of removing.
Yes, ma'am.
Okay, so that is
Yeah.
how this.
Okay.
Okay. So
Thank
any other doubts? So you people understood about how to prescribe, at least a little, how to prescribe the dose of CRRT? Okay. Okay, so this will end our today's session. So I think 2 more topics are remaining, which has to be covered by Dr. Srihari. So the recorded version will be given to you within 2 days. One is, I think it is hypercalcemia, and the other one is the metabolic alkalosis. So within 2 days, we will be giving the recorded version. Okay. So this will be completing our renal. So next system, we will update you in 1 or 2 days. Okay. You have any doubts, please put it in the group. Please, CRRT is an important topic. Okay, please go through the slides once again. If you have any doubt, you can personally ping me also. Okay. Thank you. Bye. Good night.
Thank you, ma'am.
Yeah. Bye.